in this webinar, and also I really hope that all of the participants will full attention and get all of the material from the speaker so that can be implemented in providing nursing care. I think that's all the welcome speech that I can convey. Then I will hand over it to Mrs. Murthy as a moderator. Thank you so much and enjoy the webinar. Thank you.
Thank you, Mrs. Dina Apriani, for welcoming speech from the Indonesia National Nurses Association of West Java Province. Ladies and gentlemen, for documentation, attention, please open your camera, prepare your best smile, we will take the photos. Okay, slide 1, slide 2, slide 3, slide 4, slide 5, slide 6, 7, 8, 9, and 10. Thank you. For information, the attendant link will be shared in the chat column after the last speaker has finished delivering on the material and answering questions. Entering the main session of the International Nursing webinar will be guided by a moderator. Her name is Musri Kamdah, Master of Nursing. She is a nursing doctoral student from UNISA, Malaysia, with more than 30 years of experience as a lecturer in Indonesia and Malaysia. Currently, she is a senior lecturer at the nursing program in Faculty of Science and Health and Technology, Jenderal Ahmad Yani University. Ladies and gentlemen, hopefully this International Nursing webinar event will provide new insight and knowledge about the update basic trauma and cardiac life support in the nursing services. Relax and enjoy with this webinar. Mrs. Musri Kamdah, I invite you to guide this webinar until 5:30 p.m. West Indonesia time. This time is yours. Thank you.
Thank you, Mrs. Murtiningsih. Good afternoon. Thank you all for finding time and joining today's webinar. My name is Musri Kamdah. I am a nursing lecturer at Faculty of Technology and Health Sciences, University of Jenderal Ahmad Yani, Indonesia. Now I am going to check with the audience if you can see and hear as well. My voice is clear?
Yes, very clearly.
Okay, thank you. I will quickly go through some points to note so we all have a good webinar experience. As long as you attend this seminar, if you have technical problems, please check the following basic. Is your internet connection stable? Are your computer and headphones properly connected? Is the volume level appropriate? As you have to check first. Okay. Dear audience, as has been announced, in the first day, 1st July 2023 of the International Nursing Webinar, takes the big theme, update basic trauma and cardiac life support in nursing services. Before presenting the subject, let me give a little introduction related to articles that will be delivered by the presenter. Basically, scientific forums like this are very important and interesting to follow because a lot of information will be obtained. However, it should be not that the delivery of this information will be easier to understand if the discussion runs effectively. Therefore, it is hoped that all audience will pay attention and participate in the discussion as interactive as possible. All right, then I will convey some of the provisions of our core event as follow. A speaker has 40 minutes for to deliver the subject and 20 minutes for Q&A. As long as the presenter deliver the subject, participants are not allowed to interrupt. The question and answer session will be open after the presenter have delivered their subject. We advise you to type your question in the message box. Thus, a moderator will be able to select interesting questions. Such a system will also make it easier to keep order. Now we can begin. Hello, Mr. Donald. Are you there? Hello, Mr. Donald.
Hello, good afternoon. Good afternoon, everyone.
Okay, happy hear your voice.
Yes, yes, ma'am.
Okay,
Happy to see you again. I hope
okay,
everyone is good.
thank you. First speaker in the first session is Donald S.S. Cano, B.A.S. RN, his AED RN, Master of Nursing from the Tarlac State University, Philippines. First of all, I will briefly go through her career history. First, scholastic and academic competency. He's to be top nature for 14th place on November 2015 nursing licensure examination with 33.60%. Highest board rating in Tarlac State University College of Nursing Best 2015. June 2013 to April 2015, Vice President for External Affairs of Red Cross Youth at Tarlac State University. June 2012 to April 2013, Finance Auditor of Red Cross Youth Tarlac State University. The training has ever taken course training in St. Luke's Medical Center, Quezon City, PGNT Emergency Nursing. The Philippine National Red Cross Youth Department, Leadership Formation Course Training, and Intravenous Therapy Training for Student Nurses, Ramos General Hospital Nurse Service Department. Employment, internal lecturer and national reviewer for Philippine Nursing Licensure Examination, Bachelor Science Nursing Lecturer in Tarlac State University, Philippines. He also has experience working in St. Luke's Medical Center as a staff nurse and as an academic researcher, staff and national lecturer under Dr. Carbalita, Review Center Management, Major Nursing Therapeutic and Oncology, and caring patient with cellular aberration. Okay, Mr. Donald S.S. Cano will present about highlight of guideline of 2020 American Heart Association, adult cardiac arrest algorithm. Please, Mr. Donald, you have 40 minutes for presentation, and I will remind you if the time 5 minutes left. Please, it's your moment.
Okay, thank you very much. Oh my God, 40 minutes. But before that, I wanted to say thank you for inviting me once again. It's not new that I'm here. I'm always inviting by Dr. Thank you very much for inviting me, and also for the MC. Thank you very much, and for all the supervisor and head managers of nurses in Indonesia. I also want to greet good afternoon my fellow speaker from Malaysia, Thailand, Dr. Pratuma, Ma'am Pratuma, nice to see you here again. And also our speaker from Indonesia. And of course, our students, I think we have participants, about 660 participants. I'm so just grateful that I'm here today. So basically, I am discussing with you the highlights guidelines of the updated guidelines of American Heart Association regarding the CPR, specifically the algorithm, all right, for adults. So I'm going to share my screen with you guys. Please bear with me because
Sorry, Mr. Donald, unmute. Your speaker unmute. So we cannot hear your voice. Mr. Donald, your voice
okay,
and
can you
unmute.
hear me?
Okay. Yes, thank you.
Okay, I'm so sorry.
It's okay.
Anyways, okay. I will repeat again. I will repeat. Please extend my 40 minutes. I'm so thankful for inviting me, Dr. In. Thank you very much for inviting me, to all the managers and the MC. Thank you very much. The head of the different hospitals and universities in Indonesia. Thank you very much. Also, my fellow speaker, I want to greet a good afternoon. Speaker from Malaysia, Indonesia, and also from Thailand, Dr. Pratuma, my friend. And of course, our students, thank you very much for coming. As of now, we have 667 participants. So it's not my first time to be or speaker here in Indonesia. I think this is almost 15 times already. Hopefully next time we're going to share the stage again face to face. So currently it's sunny day in the Philippines, but today I'll be discussing the guidelines of the new American Heart Association adult cardiac arrest algorithm. So please bear with me.
My apologies, Mr. Donald. Your voice unmute, please. Your laptop still unmute.
I think you have to make me as a
Okay.
host. Can you please make me a host so that when I'm presenting my materials, I'll not get mute, because when I'm when I'm presenting my materials, I'm getting a mute. So can you please make me a host for this? Okay, how about that? Okay, can you hear me?
Yes, it's
Can,
clear.
how about now? Can you hear me now?
Yes, it's clear.
Okay, yeah. We do apologize for the a technical error. It's very hard when you're doing an online seminar, especially if it's live. So I hope you can hear me clearly. So I will be discussing the highlights of the guideline of 2020 American Heart Association adult cardiac arrest. All right, so let's go. The highlights summarize the key issues and changes in the 2020 American Heart Association. So we're going to discuss the highlights in the most important part of the changes from 2010 to 2020. So CPR and emergency cardiovascular care. The 2020 are the comprehensive revision of the AHA guideline for adult. It included the adult pediatric neonatal resuscitation. For my part, I will be discussing today for the adult, and tomorrow is the pediatric one. They have been developed for resuscitation providers and AHA instructor to focus the resuscitation science and guidelines recommendations that are more significant and controversial, or those that will result in changes in resuscitation training. So they did this primarily for the instructor, okay, and also for the healthcare providers to modify, to update the guidelines, to check what is the new things that we have to do in order to increase the survival rate of the patient. Because the last revision way back before is 2010. So here is now the new guidelines for your CPR and algorithm for cardiac patient. Okay, let's see the epidemiology. In 2015, approximately there are 350,000 adults in the United States experienced the non-traumatic out-hospital cardiac arrest, meaning to say they had a cardiac arrest outside the hospital. That is about 350,000 last 2015. Okay, attended by the EMS personnel. Despite the recent gain, less than 40% of adults receive layperson-initiated CPR, meaning to say the one who performs CPR out of the 350,000, the 40% there is only performed by layperson or the bystander. Okay, and fewer than 12% have an AED only, 12% only applied before EMS arrival. After significant improvement, survival from OCA has plateaued since 2012. Out of the cardiac arrest hospital, if you can see here, the picture, 326,000 out of hospital in US, 60%, 66% in the median age happened outside the hospital, and 60% outside, 25% treated by the EMS, and 20% have initiated rhythm of VF and ventricular tachycardia. In Indonesia, according to my research, cardiac arrest outside the hospital incidence rate is estimated by 10,000 cases per year. So there's a lot also, equaling to 30 incident every day. Imagine 30 clients every day has cardiac arrests outside the hospital. That is according to Randawa et al. Last 2015. The high incidence of outside hospital cardiac arrest is also followed by a small survival rate, meaning to say the survival rate is very small, which is only 12%. Imagine, out of 30 per day, there's only 12% survival in Indonesia. The primary focus of cardiac arrest management is for us provider to optimize all critical steps, meaning to say we have to do it properly while doing the cardiac arrest management required to improve outcomes. Because if we have a good optimization, if we have good management, then we will going to have better results. Activation of emergent, what are the management that we have to improve? Number one is the activation of the emergency response. Number two is the high quality CPR. Later on, we will discuss and we will review what are the characteristics of high quality CPR and the importance of early defibrillation and advanced life support intervention. Effective post-ROSC or return of spontaneous circulation care, including careful prognostication and support during recovery and survivorship. Meaning to say, we want to improve this specific management in order for us to have and improve outcomes. So later on, we will discuss specifically this chain of survival, the resuscitation causes, the process itself. We're going to discuss one by one, and the outcomes, and the very different from outside hospital cardiac arrest to inside hospital cardiac arrest, which are reflected in the respective chain of survival. Okay, so let's check the chain of survival. Here, we are checking the chain of survival released by American Heart Association for the outside hospital. Okay, the first thing that you have to do when you're outside of the hospital and witness a client with cardiac arrest, okay, is depends on the community engagement and response. Do they know how to activate of emergency response? Do they know whom to call or who to call and when to call? Okay, the next thing is after calling, what they have to do. Do they know how to perform high quality CPR? Because most likely we're expecting the bystander to be the one who will going to perform first, because the EMS is not always readily available outside the hospital, and there is no available nurse outside the hospital. So the community should know about high quality CPR. Number three, is there available defibrillator, or do they know how to use the defibrillator? Next is advanced resuscitation, when the ambulance came, and post cardiac arrest inside the hospital, and then recovery. So this is the chain survival for the outside, okay, outside cardiac arrest client. This is very important, especially for the community. Okay, do the community knows about it? Do the community awares about it? Because it's very critical for the community members to recognize the cardiac arrest. Do they know what are the signs and symptoms of cardiac arrest? So we, healthcare provider, will be the one who will going to instruct, who will going to provide seminar in the community, so that we can achieve the good prognosis or the good result outside hospital cardiac arrest. Another thing here is adult inside healthcare, okay, meaning to say the cardiac arrest happened inside the hospital. Okay, since we are in the hospital, the first thing that you have to do is the early recognition or prevention. Okay, you can recognize the signs and symptoms of the cardiac arrest, or early prevention, those who has the higher risk. All right, because we know that the prevention is better than cure. Okay, we have to prevent as much as possible. The next thing, if there is a commit of a cardiac arrest, is the activation of the emergency response team. So you have to call the brain attack team or the cardiac arrest team, and while after the call, you have to perform high quality CPR, do the defibrillation, the post cardiac arrest, and recovery. All right, so there is no very big difference between the outside hospital. The first thing that you have to do when you're outside the hospital is to activate the emergency response, since you are outside the hospital. But when you are inside the hospital, the best thing that you can do is to prevent those clients who are high risk to have cardiac arrest. So those are the chain of survival. Okay, so what are the recommendations for us to recognize cardiac arrest? Okay, what are the things, because we said a while ago that we want to prevent, or we want to check the signs and symptoms for cardiac arrest. Number one, if a victim is unconscious or unresponsive, which has absence of breathing or only gasping, because gasping is not considered a breathing, the lay rescuer should assume the victim is on cardiac arrest. So what will we going to say to the community members or to the healthcare provider? If victim is unconscious, not breathing, and only gasping, we should assume that is cardiac arrest. Another thing here is if the victim is unresponsive or unconscious with absent or abnormal breathing, only gasping, the healthcare provider should check for a pulse for no more than 10 seconds. Okay, so after checking for unconscious, you have to check for the pulse for 10 seconds, and if there is no definite pulse is felt, should assume the victim in cardiac arrest. Okay, so those are the different thing, okay, that you want to check if the patient's really having cardiac arrest. So this is a recommendation for lay rescuer, meaning to say those are untrained, or trained, meaning to say those who are in the community, okay, community members. All rescuers should at the minimum provide chest compression for victim of cardiac arrest. So we want them to provide CPR at least minimum. After identifying the cardiac arrest, a lone responder should activate the emergency response. So the first thing that you have to do after your assessment is to provide CPR immediately. And then if you're only alone, if you're only one in the situation, then after the immediate CPR, then you have to ask for help or call for help. And then we recommend that layperson initiate CPR for presumed cardiac arrest, because the risk of no harm, because of the risk of harm to patient is low if the patient is not in cardiac arrest. Okay, so it's better for us to perform CPR compared to not assuming the patient is not having cardiac arrest. For lay rescuers trained in CPR, using chest compressions and ventilation rescue breath, it is reasonable to provide ventilation rescue breath in addition to chest compression for the adult outside the hospital. So if there is no suspected infection or if there's no suspected COVID, later we will discuss the different guidelines for COVID with cardiac arrest. Okay, so it's better to provide ventilation. All right. So after cardiac arrest is recognized, since we gathered the data and information that the client has no pulse, the client is not breathing, then the chain of survival should be followed. So you have to ask for help, perform CPR, or things should be performed according to the chain of survival. The prompt initiation of CPR is perhaps the most important intervention, meaning to say the prompt initiation, meaning to say you have to perform it immediately. You have to perform it swiftly, fastly, okay, to improve the survival of neurological outcomes. Ideally, activation of the emergency response system and initiation of CPR occur simultaneously, meaning to say at the same time as much as possible. You don't want to waste your time. So if there is someone that you can ask to call for help, then you have to perform CPR while asking for help. But if you're alone, you have to perform CPR first and then ask for help. I hope that is clear. In the current era of widespread mobile device usage and accessibility, the alone rescuer can activate. Yeah, you just have to call and ask for help using your cell phone. In the rare situation when a lone rescuer must leave the victim, for example, there is no cell phone or there is no one who can ask for help, your priority should be perform CPR first, and then after that you ask for help and then return to the client to minimize the damaging effect of the cardiac arrest. So the high quality CPR and essential drug management, okay? What are the things that we have to remember according to AHA or American Heart Association? So they said that we have to push hard. We are discussing about the adult, all right? So we have to push hard 2 to 2.4 inches or 5 to 6 centimeter, okay? 5 to 6 centimeter and fast 100 to 120 push and allow chest recoil. Okay, that is 5 to 6 centimeter, 100 to 120 push. Okay, you have to minimize the interruption. I know that you know that. You have to minimize the interruption. Do not overventilate the client. If no advanced airway, meaning to say there is no ET tube placed yet, so 30:2. Okay, 30 push and then 2 breath, okay, compression ventilation ratio. All right, so this is the high quality CPR. If you can see the picture, 100 to 120 compression at the depth of 5 to 6 centimeter. Continuous CPR, meaning to say you have to minimize the interruption and fully release between compression for you to allow chest to recoil. So how about the shock energy, the defibrillation? I hope that there is available defibrillator in the community, because here in the Philippines, I don't think so that in every places, I mean in every 10 kilometers, there's no defibrillator here. It's only found in the hospital. Or maybe the ambulance or the EMS team, maybe they have defibrillator. So assuming that we have a defibrillator, in biphasic, we can start in using 120 to 200 joules, okay? And monophasic, we can use 360 joules. Why we are defibrillating? Because we want to return back the normal rhythm of the heart. That's why we are defibrillating the client. We are delivering the electric shock. For the biphasic, how many? We have to give 120 to 200 joules first. The next thing is 360 joules for monophasic. All right. Next thing is the ROSC. Okay, we have to monitor the ROSC or return of spontaneous circulation. What is ROSC? I placed that. The ROSC is the resumption of the sustained perfusing cardiac activity, meaning to say the heart is doing properly. Significant respiratory after cardiac arrest. Sign of ROC, the sign that the client is having or returned the spontaneous circulation are moving, coughing, or breathing, along with the signs of pulse or measurable blood pressure. So that is your goal. Sudden sustained increase in PET, carbon dioxide, and spontaneous arterial pressures wave with intra-arterial monitoring. So that is the ROSC, or return of spontaneous circulation. So I just want to present to you the common drugs that is used during responding in cardiac arrest patients. So I know that you know that we are giving epinephrine. This is the most common one, intravenous or IO, 1 milligram administer as soon as possible, then every 3 to 5 minutes after, if the patient is not responding. All right. So amiodarone, the next thing, the first dose is 300 milligram bolus. The second dose is 150 milligram after. And the lidocaine, first dose we will going to give 1 to 1.5 milligram per kilogram. Second dose is 0.5 to 0.75 per kilogram. Okay, so the epinephrine, we all know that this one is used for the cardiac arrest algorithm. The action of this epinephrine is to increase the heart rate of the patient, increase the muscle contractility and conductivity of the AV node. So it has epinephrine, it has inotropic, chronotropic, and dromotropic effect. Okay, increasing the AV node. When giving intravenously, always follow the IV push with 20 ml normal saline. Remember that, all right? So that the complete dose of medication will be administered. So amiodarone, we're giving the amiodarone for unresponsive shock delivery, CPR, and as vasopressor. This is to treat also the arrhythmias, okay, the supraventricular and ventricular arrhythmias. Next one is the lidocaine. This is anti-arrhythmic drug that can be used equivalent as your amiodarone in the treatment of ventricular fibrillation or pulseless tachycardia. Okay, for adult BLS algorithm, I placed there the sources that you can check that is under your AHA for the better image. Okay, so for better image. So we have the supporting videos there, but I think we're lacking of time because I have only 40 minutes. So I'll going to push with the algorithm itself. Okay, so this is the new algorithm of the 2020. I think some of you are familiar about this. So the first thing that we have to do for the adult basic life support algorithm is we have to verify the scene. Okay, we have to verify the scene. After that, we have to check for the responsiveness. Hey, are you okay? And then shout out for nearby help. We're hoping that there is someone nearby. And then activate emergency response through mobile phone, since we're hoping that you have your own phone at the moment. Get an AED and emergency equipment. And then after that, after all checking, you have to check for no breathing or gasping. Remember that gasping is not considered a breath. Okay, so definitely check also for the pulse within 10 seconds. Okay, after checking, you have to check the right side. Normal breathing and there's a pulse, then we have to monitor until emergency arrive. But if there is no normal breathing, you check the left side. We have to provide immediately rescue breathing, 1 breath every 6 seconds. Okay, 1/6 every 6 seconds because this client has a pulse, or 10 breaths every minute. Okay, check pulse every minute. No pulse, then perform CPR. If possible, opioid overdose administered again. You have to please provide rescue breathing. How many breaths that you have to give? 1 breath every 6 seconds, or a total of 10 breaths. So let's go back here to the red one. Okay, let's go back. So assuming that the next step is Start CPR. Okay, start CPR. So perform cycle of 30 push or 30 compression and 2 breath. Okay, if there's an available AED, then use it as soon as possible. Once arrive, the AED arrive, you can use AED. And then when the AED arrives, you have to check the rhythm if it is shockable or not shockable. If it is shockable, give 1 shock and then resume CPR immediately for 2 minutes until prompted by the AED. Continue until ALS provides takeover or victim starts to move. Okay, the question here, sir, the question here, Mr. Don, after CPR, or sorry, after AED, after delivering shock, can I check the pulse? No. Okay, after delivering AED, continue CPR. Okay, continue CPR. After that cycle, then you have to check if there is no pulse. All right, because we have to minimize the interruption. So when AED comes, AED. Okay, continue until the ALS provider takes over and victims start. All right. So this one, okay, is called Jack arrest algorithm for ventricular fibrillation, ventricular tachycardia, and asystole. Okay, so we will not check the CPR quality here at the left side because we discussed that a while ago. So let's focus here for the client who have ventricular fibrillation and ventricular tachycardia. So you have to start CPR, okay, and give oxygen immediately attached to the monitor or defibrillator because this is happening inside the hospital. I remind you, this is happening inside the hospital. So you have to start CPR, hook in oxygen, and attach to the defibrillator. Then you have to check the rhythm, if it is shockable or not. Okay, let's discuss first this one, the right side. Yes, it is shockable. So upon checking, there is ventricular fibrillation and premature VT. Okay, so what will you do? You have to give the shock, deliver the shock. Make sure when you're delivering the shock, no one's holding the patient. Okay, make sure when you're delivering the shock, there is no open oxygen nearby because it may cause explosion. Okay, so you have to check that. And then after administering the shock, CPR. Okay, give 2 minutes of CPR. Okay, in IO access, you are starting the intravenous for you to give medication, and then you have to check again for the rhythm, if it is shockable or not. Okay, for the sake of the discussion, let us continue. Okay, rhythm is shockable, yes, and then CPR again for 2 minutes. Give the first dose of epinephrine every 3 to 5 minutes. Again, why we are giving the epinephrine? Because it has chromotropic, inotropic, and dromotropic effect. Okay, for cardiac contractility, cardiac rate. Okay, next, if it is shockable, if it is still shockable, then CPR again for 2 minutes. The next thing you have to give your amiodarone or lidocaine. That is to treat reversible shock. Okay, so now let's go to left side. Check the rhythm. If it is not shockable, you have to check is if asystole or PEA, and then give epinephrine as soon as possible. So you want to prepare it. That's why epinephrine is considered one of emergency drug. It should be at the nearby or bedside of the client if the client is candidate for cardiac arrest. And then CPR for 2 minutes. You are initiating the IV and IO access. Epinephrine should be given 3 to 5 minutes. And then you have to check if it is shockable or not. Okay, so this is for the ventricular fibrillation and ventricular tachycardia. In the guidelines of the 2020, there is what we call also a cycle or circular algorithm. Aside from the things that we discussed a while ago, we have what we call the cycle. So the first thing that you have to do when you say cycle, it's just a repetition. You just have to repeat the things that you have to do. So that's why it's called cycle or circular. So the first thing that you have to do is to start CPR immediately. That's the first step. Give oxygen and attach monitor to the defibrillator, and then check the rhythm if it is shockable or not. Then the next thing here is to do a continuous CPR, okay, and monitor the CPR quality and continue the CPR. Okay, so we want to achieve here is the ROSC, or return of circulation. While doing it, we are giving also the line, the drug therapy for the epinephrine, again every 3 to 5 minutes, amiodarone, and also we have to check for the reversible causes, if it is treatable or not. Okay. Next thing here is we have what we call the, for a while, the adult BLS sequence. Okay, so I'll make it simplified for everyone. Okay, so here the first line you can see is the step 1, step 2, step 3, step 4. So the first thing for the adult BLS sequence is the lay rescuer, or those not trained. Okay, the next column is the lay rescuer who are trained. Okay, meaning to say they have the seminar. And the next column is we, healthcare provider, including the nurses and doctors here. We are on the fourth column. So let's go first to the lay rescuer, to those who are not trained, meaning to say those who are community member. So the first thing that you have to do is to ensure the safety. The next thing is to check for the response of the patient. After checking for the response of the patient, you shout for the nearby help or ask someone to call 911, okay? If you are a lay rescuer and not trained. The next thing is to follow the telecommunicator instructions. So while they are having a communication through phone, so maybe there is someone who is dictating that they have to do. Then look for no breathing or only gasping at the direction of the telecommunicator, meaning to say there is someone on the phone that are instructing what to do, and follow the communicator instruction. Okay, follow the telecommunicator. That is for someone who have no background for the proper management. Okay, so now let's check for the personnel who have a training, or lay rescuer who have training. So the first thing that you have to do, if you have training, if you are a community member who has the training, is number 1, you have to ensure safety, okay, and check for the response of your client. Next is shout out for help again and ask someone to call 911. Ensure that the phone is at the side of the victim at all time, if possible. You have to do the loudspeaker, so maybe you can hear someone you are talking to and continuing CPR. Check for no breathing or only gasping. Again, gasping is not considered breathing. And then if there is no breathing, if there is no pulse, continue CPR. Okay, next step number 5, answer the dispatcher question and follow the instruction. So you have to loudspeak the phone, you have to loudspeaker the phone and answer the telecommunicator. Hello ma'am, is the patient have breathing or pulse? You have to check the breathing, you have to check the pulse, so you have to follow that. And the next thing here, send the second person to retrieve an AED if available. So ask someone to look for an AED if available. Okay, so now let's check our part as a healthcare provider here, the part of the healthcare provider. So number 1, ensure the scene is safety. The nurse should check the environment. Number 2, check for the response. Number 3, ask for help and activate the resuscitation team that can provide immediate intervention. At this time, you are checking also the breathing and the pulse of the patient, because calling for help or asking for help or asking for an EMS should be done simultaneously, meaning to say should be done at the same time. Okay, after that you have to check for the breathing, because we all know that the gasping is not breathing. Ideally, again, simultaneously. Okay, then you have to activate the AED. You have to ask for an AED if there is no pulse and there is no breathing. Okay, immediately begin CPR if there is no really pulse, if there is no really breathing, and use the AED when available. Okay, when the second rescuer arrive, provide 2 rescuer CPR. The one rescuer would do CPR and the another rescuer would do the AED or should give the defibrillation. So is there a difference between the client who had a cardiac arrest to a COVID-19 patient? Yes. Okay, so there's a difference between COVID-19 patient who had cardiac arrest. So be prepared. Now, of course, number one, we want to protect ourselves. All right. So wear your PPE, wear your goggles, face mask, and shield. I hope you have those equipment when you witnessing a client with cardiac arrest who have suspected or who have positive for COVID-19. Okay, you have to protect yourself. Okay, that's the number one rule when you're giving CPR for the patient who have COVID-19, including mask, gown, if possible. So if you can see the picture, here, there is a yellow fabric covering the mouth of the patient because that is a barrier. It protects for us not to get COVID-19. Okay, so this is from American Heart Association guidelines for those patients who have cardiac arrest with COVID-19. Okay, if an adult heart stops, you're worried that they may have COVID-19, so you can still help by performing hand-only CPR. I repeat, hand-only CPR. Okay, so no rescue breath, of course, because you don't want to contaminate yourself. You want to stay safe and you don't want to get COVID-19. So you can still help by using hand-only CPR. Step number one, you have to call 911 and get an AED as much as possible. Okay, step number two, cover your own mouth and mask. Cover your own mouth and nose with a face mask or cloth, and cover the person's mouth and nose with a face mask or cloth. Okay, so you have to protect yourself. And the next step is perform hand-only CPR. Okay, there is no difference in terms of the quality and the number and the ratio of the CPR given to the patient who have COVID-19. Okay, the only difference here is you have to cover your mouth and you have to cover the mouth of the patient. Okay, so there's no difference between the quality of the CPR. So again, you have to push hard and fast on the center of the chest at the rate of 100 to 120 compression per minute. Okay? Then step 4, use an AED as soon as it's possible. Okay? When the AED arrive. So due to COVID-19, there's increased concern for viral transmission while providing CPR. The American Heart Association recommends hand-only CPR when treating someone in cardiac arrest. Of course, you have to protect yourself also and to decrease the transmission of COVID-19. Okay. In addition to hands-only CPR and AED defibrillation, the AHA recommends placing a cover over the victim's mouth. That's what we were talking a while ago. As with any contact with the public, wear a face mask and other appropriate PPE, hand-only CPR. If the victim is wearing mask, leave it alone. Okay. Leave it in place. If the victim is not wearing face mask, cover the victim nose and mouth with a cloth, towel, or piece of clothing. But make sure that the patient has no area obstruction. Make sure that the cloth is not thick in order for him to not breathe. Okay, so make sure that it's breathable. Okay. So this is, a while ago, I present to you, this one is from American Heart Association, this one, the red, that is one from American Heart Association. This one is from the Advice from Resuscitation Council of United Kingdom. How do CPR to adult COVID-19 patients? So here they have almost the same guidelines. If someone is unconscious and not breathing, do not put your face near to theirs. Okay, call an ambulance, use a towel or piece of clothing and lay it over in the mouth or the nose of the patient. Do not do mouth-to-mouth resuscitation because it increases the chances. Okay, increases the chances of transmission. Start chest compression to the tempo of staying alive, staying alive. So there is a song in United Kingdom. So you have to, maybe you want to sing a song during CPR because that is a fast song. One of the characteristics of the CPR should be fast and deep. Okay, and use a public access defibrillator if available again. So those are difference between the CPR from the normal clients and with the COVID-19. So what is the importance of the immediate intervention for these types of clients? What is the importance? It is very imperative for us nurses to educate also the community. What is the early sign and symptoms, or how can you recognize the patient who have cardiac arrest? Because if we can identify as early as possible that the client or the patient is having a cardiac arrest, there is a high chance for us to intervene immediately. And if we have performing CPR immediately, there is a high chance of survival, good prognosis. Because if we are delayed in administering CPR, what would happen is there will be a irreversible brain damage, because only 6 minutes that there is no blood supply to your brain, it may causes irreversible brain damage. Remember that when your heart stops beating, so there will be no blood supply all throughout your body, and there are irreversible result that we can encounter. So it's better for us to give CPR immediately as soon as possible, because again, if we're going to detect it as soon as possible, if we're going to detect it as early as possible, then there will be a good prognosis. So the key factor here is the communication and education to the community members, because imagine there are 350,000 in the United States and 10,000, okay, 10,000 or 30 per day, 30 per day outside the hospital cardiac arrest in Indonesia. And in the 30 per day, okay, 30 per day in Indonesia, there is only 12% of survival. So meaning to say there's only a low survival. But if we can educate the community about the proper guidelines of the CPR and the proper chain of survival, then we can increase the prognosis and survival rate of your patient or your client. Okay, so that is the updated guidelines, and I believe other speaker will discuss more, okay, and more into depth discussion. So this is the start of our seminar. This is just a background and overview for the more deeper conversation later. Thank you very much. I'm happy to entertain questions.
Okay, thank you, Mr. Donat. I think it's many questions there. I look chat. The first question from PKM Sukapura, Nurse Ivan Suvian. He asks, if we are outside the agency, there are people with cardiac arrest, but we don't have oxygen for ventilation. Is it just compression without ventilation?
It's very, hello, can you hear me clearly?
Yes.
Okay, it's very clear a while ago. If the patient has no COVID-19, we can perform ventilation. Okay, we have to check if there is no breathing and if there is no pulse. If there is no breathing, but with pulse, you can do a rescue breath. Okay, every 6 seconds. Okay, you can do a rescue breath for ventilation. Yes.
Okay. Okay, thank you. The second question from Moknetu. Patient accident and unconscious and hemorrhage, so severe. Is it we will continue with CPR?
Can you repeat the question, ma'am? Sorry.
There are an accident and happen is the hemorrhage to be severe. Is it continue with CPR or not?
Okay. If I understand it correctly, so there is an accident, right? Yes. Accident. Yeah. And then there is a bleeding.
Yes, bleeding.
And then there is a fever. Is there a fever?
Yeah, no. It's continue with CPR or not?
Okay. First thing, when you're okay, let me clear with that. For example, you witness someone who had an accident, okay,
Mm-mm.
accident, and then with the blood loss, with the bleeding. So will you check the CPR? Okay, it should be done simultaneously. Okay, it's a different thing. Okay, it's not just a CPR alone. So the first thing you have to address is to do simultaneously. You have to address the bleeding first. Okay, you have to address the bleeding. You have to stop the bleeding. You have to stop the bleeding no matter what. Okay, because the CPR is useless if there is a bleeding or blood loss. So you have to stop the bleeding. You have to look for something, a piece of cloth to cover the bleeding, give pressure in the bleeding to maintain the hemodynamic function. Okay, you have to stop the bleeding. After that, after stopping the bleeding, ask someone, okay, to check for breathing and pulse. You have to check for the airway, okay, before performing CPR. Check for the airway, and then when there is no breathing, when there is no pulse, then perform CPR. Perform CPR while, okay, while there is no pulse. If there is no breathing, you perform CPR if there's no pulse. You perform CPR if there's no pulse. You have to control
Oh,
the bleeding at
okay.
the same time. You have to control
Okay.
the bleeding at the same time.
Okay. Okay.
So the
Okay.
problem here is, what if you're alone? Okay, what if you're alone? What if there is no one in the area? So if I will be answering that one, I'm going to look for someone, and I'm going to secure the bleeding. Okay, I will going to secure it tightly. Okay, and then proceed to CPR if there's no pulse and no breathing.
Okay. Okay. Thank you, Mr. Donald. Next question from raise hand from Timor Leste. Okay. Thank you for your
Mhm.
attention, Mr. Adelino Nuno. Okay. What is
Yes.
the question for Mr. Donald?
Yeah, thank you,
You
Madam.
can directly to Mr. Donald.
Let's say, hi sir, can you? Hi Kuya, I may call you Kuya.
Yeah. Nice. Kuya is a brother. Yeah, sure.
Yeah, I've been in the Philippines for 4 years, so I think we can connect with each other.
Oh, where do you live in the Philippines before?
It's a food. Okay. I have a question. I think this is a common concern. Since sorry, you hear me? Do you hear my voice?
It's not clear,
It's not clear.
Adelino.
Yeah.
Yes.
I just use. Hello.
Yeah.
Hello.
Hello. Okay.
Yeah. Okay. Yeah, sir. My name is Adelino from Timor Leste. Okay. Um, this is a common, I think, a common concern about the statement that you said before regarding the community should know how to operate. So my question is that who do you think the person in the community should be the key responsible to activate the call, the emergency call? Because in some community we have a
Mm.
different structure of community leaders. So
Yes.
who do you think we should
Yes.
approach first? Thank you.
Okay, very good. That's a good question. But before that, Timor Leste is what? Sorry, Timor Leste is part of Indonesia or Malaysia or Brunei. Sorry.
Before we became the part of team Indonesia, but we got our independence on 2020,
Yeah.
2002. Yeah, 2002.
Oh, I see. Nice thing. Okay. In the Philippines, the composition of our the smallest composition of the community is called barangay. Okay, it's called barangay, and in one barangay there is a community leader. Okay, which is what we call captain. Okay, the smallest community unit in the Philippines is called barangay, and each barangay has captain, and each barangay has what we call barangay health worker. The barangay health worker, the BHW. So in each community, in each small community, there is a healthcare group, okay, composed of elderly, okay, composed of women who have no job, okay, composed of men who has no job at all. So this type of community members has a special training provided by the government in the Philippines, and we have a small clinic in our barangay or in our community. So there they are providing training and supplies and materials and everything. So if I am a leader of a community, I should say there should be a designated group, okay? There should be a designated group wherein there will be a special training for each of them so that when these types of situation happened, we can tap this specific team, to immediately attend the cardiac arrest in the small community. Okay, I hope that is something to be provided by our government, that there is a training for each community member. Maybe there are 5 community members who are going to have training so that there will be no chaos. I mean, there will be no miscommunication if whom to be called during cardiac arrest. Okay, I know here in the Philippines we don't have that ideal setup yet, but I hope there is someone here, one of our participants, that someday they will become a leader of Secretary of Health and propose those types of groups or members in the community to provide training about the use of AED and how to perform proper CPR, because it's hard for us to ask for help if there is no one who is designated about it. Yeah.
Okay. Mr. Adilino, is it okay? Okay. Okay. Thank you, Mr. Donald. I think your presentation is amazing. Many questions there,
Thank you.
but the time is finished. So I say thank you for you coming to the webinar.
Thank you very much, ma'am. I'll be seeing you tomorrow for the pediatric guidelines. Thank you very
Oh,
much.
yes.
Please stay
Thank
safe,
you.
everyone.
Thank you. Okay,
You can
bye.
follow my you
Oh,
can follow my
Instagram.
Instagram. I'll be writing my Instagram here at the messages at the chat box.
Oh, yeah. Okay. Can
Thank you very
you
much.
okay? You can send to us in the chat box. Okay.
Okay, thank you.
Okay. See you tomorrow, Mr. Donald. Okay, I will read the conclusion of the speaker, Mr. Donald. The American Heart Association 2020 is to improve the management care of cardiac arrest, the improve of care in OHCA and IHCO and IHCA, outside hospital cardiac arrest and intra-hospital cardiac arrest. In outside hospital cardiac arrest, activate of emergency response, continue with CPR and defibrillation and advanced resuscitation. And in the post cardiac arrest, the patient will recover. But in intra-hospital, early recognition of prevention is the first activity. Continue with activation of emergency response and CPR with high quality. Continue with defibrillation and post-cardiac arrest and recovery. And I give attention with a high quality CPR. It's the meaning 100 until 120 times per minute with sleep 5 until 6 centimeter, continuous CPR and fully release between compressions. It's the meaning high quality of CPR. For like rescuer, chest compression only for cardiac arrest, like rescuer will be trained by nurse or doctor trained. Okay, I think it's important for the like rescuer. Okay, now we continue to the second session. Hello, Dr. Lee, are you there? Hello, Dr. Lee. Hello, Dr. Lee.
Okay, all right. Finally, thank you for unmute me.
Okay.
Right. Yeah,
Alhamdulillah.
Hai, Ibu Musri, apa kabar?
Oke, baik-baik, dokter.
Ah.
Okay, Dr. Lee, I will brief your CV first. Okay. Dr. Lee Wan Ling, doctor from University of Malaya, Malaysia. Dr. Lee Wan Ling was a practicing clinical nurse and coronary ward from 1992 till she joined the College of Nursing UMMC as educator in 2000 and became a lecturer at the Department of Nursing Science UM in 2011. She has more than 2 decades of experience in teaching and supervising nursing students in clinical area. After obtaining her PhD in 2018, she has actively involved in research activities with keen interest in mobile health, technology and education, coronary nursing, aged care, especially in long-term facilities, cross-culture adaptation and validation of questionnaire, health literacy, nursing education, critical care, and non-communicable disease. Among the current research projects she is undertaking include local adaptation and implementation of WHO. I support for dementia and expanding the development of electronic activity tracking system or EATS prototype. With a team of collaboration with international partner to build a hybrid cardiac rehabilitation program. If I see the background, I think this topic is very appropriate presented by Dr. Lee. Academic qualification, Dr. Lee, doctoral degree or PhD nursing science from University Malaya, Master of Nursing Science in clinical in coronary care nursing, University Malaya, Bachelor Nursing Science from University of Malaya as well. Certificate of Critical Care Nursing from University Malaya Medical Center or UMMC. Basic Nursing Certificate, Clinical Nursing from School of Nursing, Medical Center, University Malaya. Area of expertise Dr. Lee is e-health and electronic health and mobile health, and cardiovascular and respiratory nursing, medical nursing, infectious disease, pharmacology and nursing, and basic medical science. Non-communicable chronic disease like cardiac, diabetic, hypertension, and so on. And translation, adaptation, validation, and psychometric assessment. If the audience would like to continue the study related the technology, you can contact Dr. Lee as a supervisor. I think she is expert in this area. Okay, publication from Dr. Lee, I take to research and publication. about patients' technology readiness and e-health literacy implication for adoption and development of e-health in the COVID-19 era and beyond. And the forward, backward, and dual panel translation methods are comparable in producing semantic equivalent version of a hard quality of life questionnaire. Okay, published in International Journal of Nursing Practice. Okay, the title presentation this afternoon is to build a hybrid cardiac rehabilitation program. Please, doctor, you have 40 minutes for presentation, and I will remind you 5 minutes before the time ends. Please, your moment, doctor.
Terima kasih, Ibu Sri. Thank you for introducing me. Let me share.
My apologies, doctor. Your voice is not clear.
My voice is not clear. How about now?
It's okay.
Now?
Better.
Better, yeah? Okay. That's one thing about Wi-Fi, home Wi-Fi. Just give me a moment. Okay,
Okay.
let me see whether slideshows. Okay. Give me a moment. I'm not so familiar with Zoom. Just give me a moment, yeah. Where does it goes? Okay. Right. Okay. Are you able to see my screen?
Yes.
Okay. Right.
Okay.
Can you see it? Right.
Yes, good.
Oh, okay. Okay, should be here. Right. So, good afternoon. Salam sejahtera. Firstly, to the esteemed lecturer, academicians, beloved students, ladies, gentlemen, and everyone. I would like to congratulate Universitas Unjani for organizing this international webinar. And amazing to have 700 over participants. Yeah, that's awesome. Okay, congratulations. And I would like to take this opportunity to also thank Universitas Unjani for inviting me for this session. So what I'm going to do is very much relaxed. It's not going to be a heavy duty. It's not going to be very text-based. What I would like to do would be is to share with you the research journey on how to build a hybrid cardiac rehabilitation. So I presume most of you will be combinations from different background, right? Some might be from cardiac, some might not be from cardiac, I presume. So I'm going to start off with a little bit introduction about cardiac rehabilitation to tell you what it is about. And then I think more importantly, what's the main issue with cardiac rehabilitation, point 2. And thirdly, I would sort of like santai, casually tell you what's actually my journey, because I believe the problem that I face, the challenges that I face, I really hope that it will also enlighten you for those who are interested to develop something, should I say, services that using digitals and internet technologies, or would you like to do an mHealth project? Yeah, so that will be where we'll be heading. Okay, so let's start off with this is slides. Let me adjust the slides. Cardiac rehabilitation. So we will start off to talk about what is it, cardiac rehabilitation, what is not. I mean, for those of you who are from cardiac background, please bear with me, right? So I guess this is something you're familiar. If I'm going too fast, Ibu Musri, please slow me down, okay? If you don't mind, I will interject with bahasa, because sometimes I feel that certain terms I might need to use 2 languages, but I will try to keep to English language to benefit our international audience. Yeah? So what is cardiac rehabilitation? Now, it is a program that involves multidisciplinary team. It is not just, okay, it is not just one discipline. It is not just belong to doctors. It multidisciplinary, meaning doctors are involved, nurses are involved, physiotherapies, occupational therapies, psychology, or some centers do not have psychologists, some they have psychiatry, counselors. We also have pharmacies, right? So dietitian, yes. So you can see there is a wide range of healthcare professionals coming together to deliver a holistic program. Okay? With the main aim is to enhance the quality of life of the cardiac patients. Now, the main component is basically exercise training. Usually you will find most of a cardiac rehabilitation has an exercise component to it, because exercise is an important component, but do not get the wrong idea that it is only exercise, because I do have students have that conception. It also about health education. That's where nurses play a very crucial role. And then we also talk about the psychosocial counseling, and where the doctors come in to do medical evaluations and treatment optimization. So you can see all here is, you know, the arrays of services that we provide, okay, or components that we put into a cardiac rehabilitations. So we tailor it to the patients. So it has to be supervised, medically supervised, right? And we personalize it for each patient. Now, a cardiac rehabilitation is highly recommended for people who had a cardiac event. For instance, after heart attack, ACS, acute coronary syndromes, or a person with a heart failure, or after they undergone PCI, percutaneous coronary interventions like angioplasty, putting stenting, or any kind of heart surgeries. So after these cardiac events, and I'm putting them in the cardiac rehabilitation, we would like to bring it up to the optimum function so that they can live a life of quality. And has to be supervised, because if we do not know how the patient will respond to the cardiac rehabilitation program, now, so we need to tailor accordingly, because each patient is very different. Now, the aim, yes, I have reiterate again, the aim of the program is to limit psychological and physiological stress of coronary heart disease, can reduce the risk of mortality, improve CVS functions to help patients achieve the highest quality of life. There are many studies, you know, I do not have time to put in the references, but there are many studies, and it has been proven that cardiac rehabilitation has proven to reduce, okay, the mortality of the patients after a cardiac event. And you will see that cardiac rehabilitation has been divided into 3 phases. So the phase 1 is the clinical phase, where patients in the ward, we already started actually on day 1 in the ward. Then when they are discharged as an outpatient, they will go through a phase 2 program. Usually will last around 6 to 8 weeks, okay, depending on different center. And the last one will be the phase 3. It's more like a long-term management. These are post-cardiac rehabilitation. And each of these has an important function to play, right? So now, it has been said that cardiac rehabilitation is good. It should be recommended. However, you will find that there are certain group of people that do not seem to be taking advantage of the cardiac rehabilitation and the benefit it offers. Now, in these slides, you will see that these illustrate about who are those participants in the cardiac rehabilitations among patients with heart failure. It also applies to the others cardiac patient as well. You find that men are most likely to join the cardiac rehabilitation compared to women's, right? Okay, younger patient more than older patients. Okay, those now the thing is we have this vulnerable group that I think that if you will be interested to explore to why, what are the barriers, what are the problems, why this group of population does not seems to be optimizing cardiac rehabilitation. The women, the older one, and those who do not have cardiac procedures. So they have that sense that, oh, my disease is not so serious because no procedure, right? Then hypertension, you know, unlike if you have a heart attack, you can really feel the pain. But this one, hypertension is a silent killer. So they become asymptomatic. Sometimes they don't think that they really have the illness. And those in the non-teaching hospitals, you know, a hospital that do not really promote cardiac rehabilitations, and those who do not undergo cardiac surgery or cardiac rehabilitation. So these are the group of people, you know, deserve an extra attention. So if you read through the literature, there are many barriers, banyak halangan-halangan to why patients do not come to the hospital or medical center to have their cardiac rehabilitation program. So it's called center-based cardiac rehabilitation program. It comes to a medical center, okay, a cardiac rehabilitation center, to have the program. So you will find that among the key barriers will be number one will be work time conflict. It's always as usual. Saya kerja, I'm busy, I'm working, I don't have time. You know, I have to jaga cucu, I have to take care cucu. I don't have time, right? So that's one thing. It's always time, work time conflict. Now, I don't have time to travel so far, you know. I have to travel 1 hour, 2 hours. It's not just working. It's another thing. It's logistic. Yeah, and especially for the older person, I don't drive anymore. Nobody is driving me there, right? And I don't know how to use Grab. So these are also logistic issue. Okay, and then of course it's costs because most cardiac rehabilitation do not come free. They come with some fees. So that is an additional cost. So most of a patient do not think that cardiac rehabilitation is important. They seem to think that medication is more important. And you see that not many medical centers offer cardiac rehabilitation services, and their lack of motivations, you know, it's not easy to change lifestyle, so they don't feel motivated, and they find it difficult to comply adherence, you know, especially for those who, for instance, never exercise. Suddenly you're asking them to exercise, you know, that is really asking them to come out from their comfort zone, right? And of course, there are many other factors. And knowing these factors is important, okay, when you want to build a cardiac rehabilitation program. So then here, just briefly, I'll share with you what are pros and cons of center-based cardiac rehabilitation and home-based. Now, initially we have cardiac rehabilitation has been center-based for a very main reason. The healthcare professionals are there. We can monitor them closely. We can guide them closely. We can give that in-person's motivation, right? That's the pros. Of course, the cons, okay, the disadvantages is, as I said, okay, the inconvenience, the traveling, you know, you got to find time, you got to find transportation. So these are another reason why a lot of dropouts or many people couldn't seem to embark on a center-based cardiac rehabilitation. And therefore, because of that, some patient that we find it is stable, right? It's pretty stable. Then we will prescribe them home-based cardiac rehabilitation. So meaning we will teach them when they come for the clinic follow-up, we give them the programs, you know, some of the things they can do at home. So they will do it at home until the next visit coming to the clinic. Of course, that's the advantage, you know. They don't need to think about parking, no need to think about logistic, right? They can do it in their own time, the time that they choose. However, the con is not many people are very self-motivated. Okay, so we do not know whether a patient really do, right? That's not something, because when you do things alone, it's not that fun, right? So that is a con, some of the cons of home-based cardiac rehabilitation. because of that, therefore, we decided to merge both. We have something called hybrid. What I show this slide is basically just to show you an evolution of cardiac rehabilitation. So in the 50s, we have that traditional cardiac rehabilitation, meaning that patients go slow, okay, go steady, bit too slow, too steady. And then we did the study, we said that actually patient can step up their cardiac rehabilitation, the exercise program. So we have an intensive cardiac rehabilitation program in the 90s. And it is usually center-based. Then we discover the problems. And in the year 2000s, we bring in a home-based cardiac rehabilitation, and we discover also another problem. Now we decided to bring in hybrid, where we merge both center-based and home-based, right? And then later we will talk about the futures of the cardiac rehabilitation. I think it's going to be exciting. You can see from here the hybrid cardiac rehabilitations. The word hybrid meaning combinations. You got to have the in-person center-based. They must come to the medical center because the doctors need to see them, assess them. The physiotherapy nurses need to see them. Okay, have a physical assessment of them. You can't really do that from far, even though remote. Even though you have a Zoom to see a patient, is nothing like touching them, inspecting them in person. And then you also need to have a component where they will do at home. Okay, they will do at home, right? Sorry, they have to do at home. Where you can have that kind of telemedicines. They can exercise with the physiotherapy through the Zoom sessions. So there is a connection from home base to the center base. It can be synchronous, meaning live sessions. It also can be asynchronous, meaning you tell the patients what to do. They choose their time, they do it in their own time, but you need to follow up with them. You need to know how are they doing, and do they have any symptom, do they have any problem. So in the past, we have been always give a phone call to the patient, to follow up with them. Okay. Now, with the advancement of technology, the digital evolutions, we are able to do more than just a phone call. I remember in those days, we have even devices initially, the pedometers. These are those little device. If you remember last time, we used to put it there, and then when we exercise, it will capture how many steps we are. Right? But this has become obsolete. Obsolete already when a smartphone comes in, because it seems like the smartphone has also inbuilt pedometer in it. And even smartphone, have you ever seen those people jogging around and then carry their smartphone strapped to their arms, right, or carry in their pocket? And they can even count their steps, right? Right. So then what really happened the next will be exciting when there is advancement of wearable technology. Wearable technology like the watch, smart watch that you can see from here, which is so convenient. If you wear the phone, strap it to the arms, it's so bulky, sometimes not very convenient. But a watch, because watch is like second nature to us. Everybody wear a watch, even myself wear a watch. Yeah. So when they wear a watch, everything seems to be connected through the watch. Yeah, the watch will have interface to the phone, right? And that's sort of actually open up, okay, with the available of this wearable device smartwatch. Actually, it's kind of like a moving cardiac rehabilitation to another exciting phase, right? Which I'm going to share with you. How does the journey starts like? And if I guess you already heard about the AIs, artificial intelligence, right? The ChatGPTs, okay? The IoT, Internet of Things. These are all coming technology which will propel cardiac rehabilitation program to a more exciting level. But the work is still in progress. So there are many, works that's ongoing regarding about mHealth, and it's pretty exciting. Okay, so what I did, okay, so what I did so far is that to develop, okay, mHealth. on cardiac rehabilitation. So what we have is we will have a fitness trackers. Now the thing is, there is a fitness trackers, or we call it a smart band, smart watch. Now that here I will refer it as a fitness tracker. It's already available commercially. Commercially, they are not yet a medical device, but the fact that they are available, and then there are studies been validating it, they are of decent accuracy. And with that coming in, now we will be able to monitor patients. So patients just need to strap on, okay, the watch. Now, the thing is, not only do they put in the steps count, you know, sometimes the problem with steps count, I can shake the device and will tell you I'm not exercising, I'm shaking the device, right? I just can shake, and it can give me 10,000 steps, okay? Can give me the false reading. But what's the thing that find it harder for anyone to cheat would be the heart rate. And heart rate is a thing that is very important in the wearable device, because when you want a person to exercise, you want them to exercise to that targeted heart rate, and it will be captured decently by the wearables. And that sort of like revolutionize cardiac rehabilitations. Open up, okay, the e-cardiac rehabilitations or mHealth or whatever terms that you use. Now you will see literature using a lot of terms, but they're basically talking about technology, okay, using technology in your cardiac rehabilitation. And of course, the watch, okay, whatever is in the watch is also, okay, stored into the phone apps. Now, I'm sure all of you are very familiar with phone apps. That's where you were able to read, okay, in details all your report, right? That in fact is very interesting, because it allows the persons to be able to be knowing their progress, self-monitoring themselves. Okay, so all this while, the product out there is basically for patients to self-monitor. So I have my watch, I have my phone. So I exercise, capture my phone, and I read it, and I self-monitor. There is no interface between this device to the healthcare professional. So we as a healthcare professional at the other end do not know what's happening to the patient. So we either through phone calls, right, the old time, or we have to wait them to come, okay, come to the clinic or come to the medical center and ask them, okay, can you show me your phone, and see their progress, right? So these are the things that we can do. However, with the IoT technology, Internet of Things technology, where we can see what we will do is we can extract. So you see that whatever data that you see in the phone, in the manufacturers, I do not want to use the name of the manufacturers for confidentiality purpose, but you know all the products, all the companies out there. So this company, they have a cloud storage. So all the consumer data is being stored in their cloud storage. So you need to extract the data, okay, from the cloud storage to your own system, right? So we developed this, okay, your own system where you'll be able to see your patient care progress, meaning you don't need to make phone call. You have a system where the patient's heart rate, patient exercise is all in the web base, where the health professional can monitor and can send messages or give a phone call if whatever intervention needed. And even you can also send an auto reminder for a patient if they have not exercised or they have not exercised according to prescription, or they exceed the targeted heart rate level. So these are things the healthcare professional can sort of communicate, okay, with the patient. So this is part that very crucial. So if you have a device that do not connect to the healthcare professional, the system will not complete, because you will know that most of the time patients require support, and we are the healthcare professional is the crucial support that they need, especially at the beginning, right? So this is just an overview of the prototype that we have developed, right? So how many minutes do I have? Okay, now I will, this is almost third last. What I would do is I share my research journey at UMFIT, so that I hope that you know, whatever the downfall that I experienced, that you can learn from it. So when you start your project, these are the things that hopefully will benefit you. So the idea of mHealth in the very beginning, way back in 2017, the idea came is because when I did my PhD, yeah, I spoke to a lot of patients. I heard sad story about patients. The one thing that I find is really, touching me is that some patients, they want to do cardiac rehabilitation, but they can't because they stay too far. You know, some of them stay too far from medical center, impossible. They got to work. And I see these are young patients. Okay? They are in their 40s, 50s. So, and when I see the product at that time, you know, the wearables, the smart bands become popular in the commercial market, it gives me an idea, hey, there is something that we can do. At that moment, it is not the buzz thing yet, because I've been going around, you know, I've been asking anybody interested to do mHealth project. Never, I couldn't seem to navigate myself around. So what I learned in life, first thing, you got to be thick skin. Okay? Thick skin, you got to be asked around. So what I did is, you find the right person. Now you find who are the person thing that has the expertise. You talk to the person. So what I did at that time, I approached my deputy dean research, and I shared with him this idea. Right? I even talked to my dean, and so at that time, he referred me to another company. So that at that time, there is an actually company. So we do not want to do things from the scratch. So whatever it is you do, look at your surroundings, see whatever existing technology that you can use. So you do not need to start from the very beginning. We do not have the capacity to build the wearables. So there is a company. So what I did is, yes, I forged a collaboration with the company, and then we look for grant, and then there's grant. Of course, when we apply for grant, there is rejection. No worries, put it again. All right, one rejection, never mind. Put it until you succeed. So finally, I managed to get a small grant. Okay, because at that time I'm just beginning lecturer. I joined academia quite late, and they gave me a small grant. Right, so I have a team whereby consists of the cardiac physicians. So you have somebody have the technology, you would like to collaborate with them. Okay. They are one thing I must say, that they are business entity. Yeah. So they are, whatever they see, things do not really sync with what you believe in. Like me, I believe in the very beginning, I believe that mHealth should be affordable. It shouldn't be expensive. It has always been my belief. Now, if no point if you have a very expensive mHealth, it will benefit only those who can afford. But what about those the disadvantaged group? They will not be able to afford it. Yeah. Therefore, okay. So we have the company coming in, and then I mean, cardiac. We have a cardiac rehab physicians. There is no problem, because we're always talking about the same thing. We have a lot of conversation. The only problem I face is finding who are the IT experts, because we are nurses. This is something that beyond us. However, having said that, you know, it doesn't mean that nurses cannot do something out of their boundaries. Now you can explore, yeah, and you just need to have the skills to put the puzzles together. So I have to go around, merisik, yeah, in the Malay called merisik, hunt around, and then at that time you will find, you know, finding people that as interested as you are, because it is like your project, you are very excited, you're very passionate about it, but finding the people to be as passionate as you are might not be straightforward. You know, they will say, yeah, okay. Okay. It takes a while for them to spark that interest. Yeah, but I guess if you keep to your enthusiasm, eventually it will rub off, and then they get excited. as excited as you. That's the very beginning. And yes, along the way, we have tunang, kawin, cerai. Yeah, sometime along the way, you find that your collaborators does not seem to work well. Then you have to make them broke. I'm not the type of person like to sort of break things, but sometimes you need to be very clear in your communication with your collaborators. So I do have collaborators. I have no choice. In a nice way, we will depart. Cerai dengan aman, and find a new one. So that is the beginning in 2018. It's a hard journey, okay? It's a very hard journey. So I don't know who, I literally do not know who to approach, but it's a go around. You will find that as you talk to people, they will refer you to this, refer you to that, and they end up you get the person. You might get the right match, but it's okay. We learn along the way. However, we managed to get a grant, we get the students, and then we started that validating the device, right? We have to validate. We want to be sure that the device is accurate. Then the next one, boom, in 2020, when COVID-19 hit, that's where you will see everything, the digitalizations of healthcare is just exponentially exploded. And at that time, it's so hard to get people to start this mHealth project. At that time, it's just exponential. So now, everybody is doing it. Now it's become the D thing. The apps are everywhere. Everybody seems to be doing apps. Everybody embarking on mHealth. So that's where you will see, there's a blessing in COVID-19 pandemic, right? So at that time, we even see even myself become more convinced, because at the beginning it's very hard. There are a few times you want to give up. At that time, when the pandemic comes in, each of us, myself, my collaborators, become more convinced. Hey, this is the way to go. We need to digitalize cardiac rehabilitation services. It's no longer actually an option the way we see it, because we do not know when will the pandemic strike again, or outbreak strike again, but we touch wood. We do not know, right? And then, as I mentioned, there is a benefit of using, should I say, remote or e-cardiac rehabilitations. Therefore, we move forward, right? As being a nurse, to lead that project at the beginning is hard, because I couldn't find the people to really develop it. So what I do is I sort of encourage my collaborators from the Faculty of Computer Science and Information Technology. These are the IT experts. I convince them, hey, why don't you take, I'm really, we work as equal share, because I don't believe that just because I started the project, I lead the project, so I should stay on top all the time. But what I do is I see we should be equal partners, give them the equal partnership, right? So when my collaborator decided to take ownership, boom, she will apply for the grants, and then she got the grant. Of course, we will give her all the support when we got the grant. And we can see now she's moving tremendously, right? Because this is her area, digital is her area of expert. So she's able to develop it very fast. She get all the students, if I don't have students in IT. So I have to hire people, right? And she get all the students in to do the project, and now she have ideas. So she has really moved it, okay? She has a leap and bound forwards, and I'm excited to see the end product of her prototype. Now, so what we do is we have this very primitive prototype. Okay, it's always start with something. You do not wait everything to be there, so you just start. Okay, whatever prototype imperfect it is so imperfect, and then along the way, okay, you make it better and better, because we learn along the way. So now in 2023, we will see more additional features is being added to it, right? Due to the confidentialities of the project, I'm not able to indulge more about the projects because it is IP protected. Yeah. So that's the journey, you know, how to start hybrid, okay, cardiac rehabilitation. You just have to start somewhere. And we have all the technology, and even the technology out there, they are not perfect. Yeah, they are not perfect, but you can always use existing technology and you go along the way, because I believe even the manufacturer of the technology, they would like to improve their products. So they'll be more happy to collaborate with you. So at that time, what I would like to also add in here, which I forget, is finding the companies that you work with is very important. So there's one time the smartwatch device come from a company which is HQ based in China. So you have to be, you have to work with the company because you're extracting data from them. So if there is a breakdown of data extraction, you can't receive the data, you have to communicate with them. The communication have to be fast. So I find that that's a real problem. Now we have the company in China, not many of them know English, right? Their use of English is limited. So we have communication problems. We find it very hard, to get things done fast. And finally, after the pandemics, after the crisis of the pandemic, when Malaysia no longer under lockdown, okay, we open up of economy, then we decided to meet another company, the manufacturer of the device, and so happened that we choose a company because it is based in Malaysia. It has a base in Malaysia, and then therefore it's easier, it's faster, okay, to communicate if you have a collaborator that is based in Malaysia. And also when we want to choose company, what makes us choose company? There are many. But I will always believe that if you want to have mHealth, okay, program, it has to be affordable. That is my philosophy. It has to be affordable. So I do market survey of all the devices. I choose the one, okay, of a lower range. Of course, there's high range, but I choose the one in lower range, where I feel that those in the lower income group will be able to afford it, because somehow or other, okay, when you have mHealth, it doesn't come free. It has a cost, so you have to think about the cost. And of course, as excited as mHealth it is, it also not perfect. It has other issues, which I'm free to share if we have time. All right. So what's next in the future? Okay, you will find that there will be more coming in with the AI technology. People are looking into embarking on AI technologies, because you'll find that how many physiotherapists are there? Not many. How many cardiac rehabilitation? There are not many. So if some of those processes can be automated using AI, of course, that will be sort of reduce the load, okay? The requirement for manpower. So that's one thing. There are many are excited. You can read through the literature and you can see what are the things that people have started to dream about and building about, to build a cardiac rehabilitation that works for the patient. Right. Now, all this, it's not perfect. Yeah? One of the biggest problem with mHealth is the digital divide. But I guess what is digital divide? Meaning that there are some area has good internet connectivity. If you have this kind of intervention, you need to use internet. So there are some area with low internet connectivity. There are some with good. So that is a problem. We all of us discover, when the pandemic hit, when we decided when everything go digitalized, then we realize how huge is the problem of digital divide. And of course, there are people try to narrow the gap, the digital divide. Okay, the older people struggling to use it as user-friendly as possible. Otherwise, people will not be using it. Okay, and what else? These are the two. Okay, digital divide is the thing that we are trying to look at, and affordabilities. Right. These are the major barriers to successful adoptions of the mHealth. And on the other hand, I guess another thing is there will be barriers also coming from the healthcare professional. How many healthcare professionals really think that mHealth really sort of reduce their workload? Okay, some of them will perceive it reduce more, it will increase their workload. So you have to have a system that, that do not add to their workload, because they already got a lot of work to do. Now, so having said that, so I come to an end with a take-home message for the audience there. Now, if you, even though I thought from a perspective of cardiac rehabilitation, but mHealth, you can use it for other discipline or other intervention. You think it will benefit your patients. So I would say number one is to dare to lead. Being a nurse, you're always afraid to lead. I say nurses, like me, I know, like me, I know nothing about IT when I started the project. I don't even know how to operate a Skype or even on a Zoom. I only learned it during the pandemic, but I know what's my patient need. Okay? I know I can see the needs is coming. So dare to take the lead. Okay, take the challenge. Life will always have challenge. So just take the challenge and forge and effective collaborations. Because the people I forced collaborations, we started with total stranger, honestly, total stranger. I remember I knocked on the door, would you be interested? I even asked the deputy dean of faculty of computer science, do you know anybody you can recommend to me that I can approach, and ask whether they're willing to join? That kind of door-to-door thing that I do. But these people from a complete stranger has become a very good friend, a close friend. We share the same vision. We're excited on this journey together. So force an effective collaboration so that you won't feel lonely in this journey. And of course, the best thing is to learn by doing it, start somewhere, you fall down, never mind, you trip, never mind, you just get up and continue. And it is important that you be updated. So if you're in this field, you need to be updated. What is the coming next? So that, because you see that digital technology or internet technology, they evolve very fast. Sometimes I find it very difficult to keep up with. So you have to be updated. What's going on around the world? So what are the new products is coming in? What are the new features is coming in? And last thing is, our world is not perfect. There is no perfect interventions. There's no perfect solutions. But we were trying our best to do what we think would be one of the solutions to the problems of the world, because we have too many problems, not enough solutions. Having said that, I will end with a thank you for the attentions, right? And I'll be more than happy to take any questions from the members of the floor.
Okay, thank you, Dr. Lee. It's awesome, awesome presentation. And any question from the audience? Oh, hands up. Okay, from Darnianti. Okay, Darnianti, can you hear me? Oh, raise hand, but nobody there. Okay, from Rumah Sakit DKT Suci. Okay, hello.
Hello.
Okay, please.
Hello, doctor.
Okay.
I want question. How long cardiac rehabilitation for patient with cardiac ring insertion can be healthy normally again? Thank you very much.
So the question is, how long does cardiac rehabilitation with what?
How long cardiac rehabilitation for patient with cardiac ring insertion?
Okay.
Okay.
Can be healthy normally again.
Okay. So usually, phase 1 in a hospital, how long they stay in hospital. If they're in hospital, it's considered phase 1. When they discharge, first thing is they has to be certified fit enough to join the outpatient cardiac rehabilitation. How long it takes? On the general, it takes about 4 to 6 weeks. That is normal. However, having said that, it really depends on the patient. Some patients who are more functional affected, they go a bit slow because we tailor it. We do gradual. So certain patients, it can be extended. The phase 2 can be extended beyond 8 weeks up to 10 weeks, sometimes even 12 weeks. Okay, so it has to be case by case basis. So generally, I would say that 6 to 8 weeks it takes for most cardiac patients in the phase 2.
Okay, thank you, Doctor.
You're welcome.
Okay. Any question again? Oh, still connecting, Doctor. Okay. This is one question from you, Doctor, from the audience. What the big problem you face when implement the hybrid cardiac rehabilitation in Malaysia, and how you solve the problem?
Thank you so much for the questions. That is really, really a good questions. Yeah. Right. Very good. I'm happy that you asked the question. Give me opportunity to share you what we're experiencing right now as we run in hybrid cardiac rehabilitation. Okay, number one, it is the technical problems. Number one is a technical problem because we will find that mHealth is still at the stage. I would say it's still at infant stage. So there is a hiccup in terms of data. We have problems, extracting data because we need to, you need to find people to code. It's very complex. We want to get the coding. They need to find ways to extract data without any loss or break should I say terputus. That's number one. See? Number two, would be patient itself. So when we do the study, we give them the device. What we find out is the issue is those we have a large number of patients who are not savvy IT, not so good with IT. So we have an issue, convince them, we will give them support, right? So you have to have a training to train them how to use. So we create a lot of videos, video clips, even to teach them, hey, how do you sync? How do you pair your device to the phone? Okay, that's one thing. And then sometimes they forget to pair, they sync their phone because the data is captured in the watch, but they need to sort of connect to the internet and then send the data to the phone. So the phone data will be stored in the cloud storage where we can extract. Sometimes they forget, so we sometimes have to remind them, right? These are no issue. And then another one is costing. So some of them will be very worried about costing because, as you know, it's expensive to fall sick. Cardiac patients, sometimes they spend thousands of dollars, but they spend easily, up to sometimes $1,000 1,000 RM for their medicine alone. And when we bring this in, they will be asking. And then we have that issue, whether this patient will take up, especially for lower income company, because there is no insurance coverage for this kind of services so far yet. But this is a subject that we can, these are the area that I believe some of those, my colleague is looking into, proposing, should I say, insurance coverage, right? Another issue will be we did feasibility studies. We find that it's always a problem of technical glitches. They find, how to operate. They keep on forgetting. So you need to, you need to also don't just device and handphone. You need to have additional platform. You need to create WhatsApp. Okay, so then whenever they have a problem, okay, they will always contact you. So that itself already a problem, because the healthcare professional feel, at the moment, they say that, wow, we need to be there to be a help centers, right? If they have problem, alamak, terlupa which button to press, straight away WhatsApp, I'll be busy, I'll be more busy, see? So that is the beginning. However, what we think is, once we put in an additional module like AI self-help, okay, meaning that the healthcare profession no need to attend, but it can be facilitated by AI, that will be an exciting milestone ahead. So at the moment, it's still very primitive, I would say. So we have to be there to give them the support, if they forget which button, okay, as simple as that, okay, this button, that button, okay, like that. And for the older people, it's a challenge, okay, to adopt this technology. But having said that, after the pandemic, a lot of older people are opened up to be more receptive. What you need to do would be pair them up with the children. So so not just older people, pair them up with the children. So in case when they have any problems, and especially in the middle of the night, out of the office hours, and they can also contact their children, to have a look at it, troubleshoot. So these are the things. But I believe these are issues that slowly will be fading away, because I can see the older generation, the older people are slowly pick up, okay, IT literacy, become better and better, okay, in using all this technology. So I feel it shouldn't be a big block to that. Okay, these are offhand that we think of. Now, the only thing now, the next is how do we scale it? Because we are still at a much of the feasibility stage. Because to scale up, we need more fund, right? We need more fund, and you need to think about the business model. So we have to figure out what's next. We built the prototype. We are looking for a company comes, because once you develop a prototype, so what's next? Somebody need to pay the cloud hosting, because the data is stored there. Somebody need to pay the cloud hostings. You need to have a company that manage. So we're looking into that. So in this kind of technology, it's best that you also work with a company, right, to have a business model. So it is sustainable. Otherwise, the project will just finish, money finish, that's it, just stop. It would be a waste. So sustainability is one thing we also look into. All right. I think these are the major problem that I can think of offhand. Thank you so much for the question. I'm glad that you asked that. Yeah, but they are solvable. Don't give up. Okay, problems are there to be solved.
Okay, thank you, Doctor. I think the time is up. And if you any another activities, could you please leave this webinar?
Thank you so much. Thank you so much, Ibu Musri. Thank you, everyone. Have a nice day.
See you tomorrow.
Bye.
Bye. Okay. That are from the second speaker, Dr. Lee Wan Ling. Okay, I would read the conclusion of the second session. Cardiac rehabilitation content of clinical phase, outpatient cardiac rehabilitasi, and post-cardiac rehabilitation. Okay, hybrid, the meaning is combination of center-based and home-based cardiac rehabilitation services. Hybrid can do regarding with development of technology, and you can go along the way with technology for better and better. But however, there are many barriers when to do the development for hybrid. about the time, about the support, about the chance. So start hybrid research journey hybrid from 2018 until 23. This research they do with the student, especially master student or PhD student. Okay. Take home message for implement the cardiac rehabilitation with dare to lead and take the challenge, 4G effective collaboration, learn by doing, be update, and our work is not perfect. Jadi kalau saya simpulkan dari apa yang dibicarakan oleh Dr. Lee, bahwa rehabilitasi ini atau cardiac rehabilitation atau rehabilitasi kardiak ini terdiri dari 3 hal yang penting, yaitu tentang fase klinik, fase cardiac outpatient, dan post cardiac rehabilitation. Jadi ada 3 hal ini yang penting. Ya. Sedangkan hybrid ini adalah kombinasi daripada pusat rehabilitasi dan perawatan di rumah tentang pelayanan kardiak rehabilitasi. Ya. Hybrid ini dapat dilakukan seiring dengan berkembangnya teknologi. Ya. Jadi ini bisa dilakukan jadi bertambah baik setiap waktunya. Jadi bertambah baik lagi, ya. Tetapi bagaimanapun untuk hybrid ini ada bariernya atau ada halangannya. Ya, seperti apa? Seperti waktu, kesempatan, kemauan, semangat, biaya, dan support dari environment dari sekitarnya. Ya. Kalau nggak ada support dari sekitarnya, ini susah untuk dilakukan. Ya. Kalau di sana rehabilitasi ini revolusi mulai dari tahun 1950 ya, sampai kemudian tahun 2010 ada hybrid yang terus dikembangkan sampai sekarang. UM sendiri mengembangkan yang namanya sharing research journey itu mulai tahun 2018 ya sampai sekarang. Nah, dalam perkembangan atau implementasi untuk research mengenai hybrid ini biasanya dikerjakan bersamaan dengan mahasiswa ya. Mahasiswa baik master maupun PhD. Mereka akan fokus ke pengembangan teknologi untuk kardiak rehabilitasi ini. Ya. Kemudian di sini yang penting adalah harus berani mengambil kesempatan. Ya, kemudian harus memanfaatkan kolaborasi yang efektif, kemudian belajar sambil learn by doing, ya. Kemudian harus selalu update dan kita berpikir bahwa dunia itu tidak sempurna, gitu katanya beliau ya. Jadi itu adalah ringkasan daripada Dr. Lee Wan Ling yang hari ini membicarakan tentang kardiak rehabilitasi. Tadi ada yang minta untuk yang materi Dokter Donald untuk diterjemahkan dalam bahasa Indonesia. Kalau tadi lebih kurangnya bahwa AHA, ya, American Heart Association atau AHA tahun 2020 ini adalah penyempurnaan daripada prosedur AHA untuk yang yang lalu ya. Biasanya ini setiap 5 tahun selalu update ya. AHA untuk 2020 atau American Heart Association untuk ini itu adalah untuk memperbaiki penata laksanaan daripada cardiac arrest atau henti jantung ya. Baik itu di out hospital cardiac arrest maupun intra-hospital cardiac arrest, baik di dalam maupun di luar rumah sakit. Ya. Penata laksanaan yang di luar rumah sakit itu yang pertama adalah aktivasi untuk emergency, ya, aktivasi emergency response, ya. Kemudian dilanjutkan dengan CPR, ya, high quality CPR atau CPR yang berkualitas tinggi. Kemudian disambung dengan defibrillation, kemudian melakukan advance resusitasi, dan kemudian post cardiac care yang diakhiri dengan recovery. Ya. Kemudian kalau intrahospital ini di sana melibatkan banyak sekali expert. Ya. Di dalam intrahospital cardiac arrest, di sana yang pertama dilakukan adalah early recognition of prevention, ya. Kemudian dilanjutkan dengan aktivasi of emergency response, kemudian dilakukan high quality CPR, kemudian defibrilasi, dan kemudian post cardiac arrest care dan recovery, ya. Yang saya fokuskan terutama di sini adalah high quality CPR. Seperti apa high quality CPR ini yang memang menjadi poin penting dalam kita membantu pasien untuk kardiak ini. Yang pertama adalah sekali pas atau melakukan penekanan itu lebih kurang 100 sampai 120 kali per menit, kemudian dengan kedalaman 5 sampai 6 cm. Ini sesuai dengan kedalaman jantung, ya. Kemudian continuous CPR, dan ini harus ada jarak gitu ya, dengan melihat fully release between compression. Jadi benar-benar dadanya itu kembali baru kemudian ditekan kembali, ya. Ini adalah high quality untuk CPR, ya. Kemudian untuk orang awam atau lay rescuer ini biasanya di sana di Filipina, mungkin di kita juga ya, itu orang awam itu dilatih untuk menolong kalau ada terjadi cardiac arrest, yaitu menolongnya dilatih orang-orang yang sudah mempunyai sertifikat atau trainer, kemudian mereka ini, orang awam ini dilatih hanya chest compression saja. Ya, chest compression saja, tidak yang lainnya. Ya, saya rasa itu adalah conclusion atau kesimpulan daripada Mr. Donald tadi. Ya, oke, yang sebagian audien minta dalam bahasa Indonesia. No, we will continue with the third speaker. Oke, hello Pak Welas. I'm sorry. The speaker, third speaker is Associate Professor Dr. Pratuma Ritpo. Hello, Dr. Pratuma.
Selamat sore, I'm sure.
Nice to meet you, Doctor.
Yes.
Okay.
Yes,
Can you speak selamat sore, Doctor?
Yeah, selamat sore. I'm not sure. Yeah.
I love it. Okay. Before your presentation, I will brief your CV to the audience. Professor Dr. Pratuma Ritpo from Division of Maternal and Newborn Nursing Department Nursing Department of Nursing, Faculty of Nursing, Naresuan University, Thailand. Okay. Okay. He have education in 2000, Bachelor of Nursing Science from Faculty of Nursing, Naresuan University, Thailand. In 2003, Master of Nursing Science, Nursing Care of Women from Faculty of Nursing, Chiang Mai University, Thailand. And 2010, PhD in Nursing with International Program from Faculty of Nursing, Chiang Mai University, Thailand. She have experience in 2000 as a staff nurse in patient department Ramchat Hospital, Nakhon Sawan, Thailand. In 2000 until now, as a lecturer, Department of Adult Nursing and Sub-Department of Maternal and Newborn Nursing, Department of Nursing, Faculty of Nursing, Naresuan University, Pitsanulok, Thailand. Field of interest in HIV/AIDS, sexual transmitted disease, women's health nursing, vulnerable population, maternal and fetal health, and midwifery nursing. Okay, and editorial board or journal reviewer in 2007 until present, journal reviewer of Journal of Nursing and Health Sciences, and 2015 until present, journal reviewer of Journal of the International Association of Nurses in AIDS Care. Okay. She have invention in product like NU cervical dilatation model, NU placenta model, NU cervical effacement model, and breast examination model. C2B members in Thailand Nursing and Midwifery Council, the Nurses Association of Thailand, Faculty of Nursing, Chiang Mai University Alumni Association. She get rewards in 2017 and certificate of outstanding contribution in reviewing and recognition of the contribution made to the quality of the journal from Elsevier in cooperation with Association of Nurses in AIDS Care. In 2017, certificate of reviewing in recognition of the contribution made of the journal from Elsevier in cooperation with Association of Nurses AIDS Care. Okay. The title today is about update maternal and child nurse emergency nursing. Okay, Prof, you have 40 minutes for presentation, and I will remind you in 5 minutes left. Okay,
Yeah.
Please deliver your speech.
I'm sorry. Okay, can you hear me? Okay.
It's not clear your voice, Doctor.
Okay.
Prof.
I'm sorry. Wait a minute. I changed those. Okay, I will change some. I'm sorry. Okay. Some audio. Yes. Okay. Okay.
Okay.
Okay. Thank you very much for your introduction. Okay. Let me share my slide. Okay. Sorry.
Hey.
Okay. Okay. Good afternoon, the guest speaker and participant. I also appreciate to be speaker and I'm waiting to visit your country again. I'm really impressed Indonesia, especially Bromo and Borobudur Temple. Today, I would like to present my topic, update cardiac and trauma life support for maternal and newborn. I'm trying to summarize the new intervention in 40 minutes. Yeah. Okay. Pregnant women are particularly vulnerable to oxygen deprivation caused by cardiac arrest. During pregnancy, the fetus requires significant amount of oxygen from the mother. In fact, women experience a 20% increase in oxygen and consumption and a 40% increase in cardiovascular metabolism to accommodate the fetus. Altered level of hormone like progesterone and estrogen during pregnancy can also restrict air passage and exacerbate the danger associated with maternal cardiac arrest. The physiological change in combination make cardiac arrest and especially life-threatening condition in pregnancy women. Therefore, when pregnant women suffer from sudden cardiac arrest, it's critical to perform high-quality CPR with rescue risk and to use an AED immediately. Then this topic that I will present today. 99% of the world maternal deaths occur in developing countries. Every year, 1 in 13 children in sub-Saharan Africa die before their 5th birthday, compared to 1 in almost 200 in high-income countries. Most of these deaths are preventable. We can see our country, Thailand and Indonesia, and you can compare this color, and then you will try to find intervention to reduce maternal mortality ratio. Yeah. Maternal mortality is unacceptable high. About 195,000 women died during and following pregnancy and childbirth in 2017. The vast majority of the deaths, 94% occur in low resource settings, and most occur have been prevented. Key facts from World Health Organization mentioned that every day in 2017, approximately more than 800 women die from preventable causes related to pregnancy and childbirth. Between 2000 to 2017, the MMR dropped by about 38 worldwide. 94% of all maternal deaths occur in low and lower income countries, maybe Indonesia and Thailand also. Young adolescent age 10 to 14 face higher risk of complication and death as a result of pregnancy than other women. Skill care during and after childbirth can save the life of women and newborn. That's why we should learn more how to CPR women, pregnancy women and newborn. Cardiac arrest management, basic life support, the cardiac in pregnancy in hospital BLS algorithm should be used as a guide to management. And I think every hospital should apply and promote the staff to do CPR in pregnancy well. Improve maternal health is one of World Health Organization key priorities. World Health Organization work to contribute to the reduction of maternal mortality by increased research evidence, provide evidence-based clinical and programmatic guidance, setting global standards, and provide technical support to member states on developing and implementing effective policy and program, identify in ending preventable maternal mortality rate. World Health Organization work with our partner in supporting countries to rise is addressing inequality in access to and quality of reproductive, maternal, and newborn healthcare services, ensuring universal health coverage for comprehensive reproductive, maternal, and newborn healthcare, addressing all causes of maternal mortality, reproductive, and maternal morbidity and related disability, strengthening our health system to collect high quality data in order to respond to the needs and priority of women and girls, and ensuring accountability in order to improve quality of care and equality. I know that Indonesia, you have more than 17,000 Iceland. Maybe it's very hard to do, but we must try to reduce the MMR rates. For years, the USA has been considered one of the unsafest places to give birth among developed nations.
in 2018, the USA MMR rate was very low, but in 2021, that rate surged, increased for every 10,000 live birth. More than half of all maternal deaths happen during the postpartum period, and those data have been part of the big pulse among U.S. health advocates to offer pregnant and postpartum people Medicaid throughout the 12 months after gave birth, up from 6 months in the past. This slide presents MMR in our region. The high number of MMR in some area of the world reflect inequality in access to quality health services and highlight the gap between rich and poor. You can see MMR rate in your country. Yeah, did it? Yeah. I searched from this source. Therefore, you should think more about the intervention to reduce death and effective CPR program in each part of quality of care among this group. This is Singapore, Malaysia, Thailand, Vietnam. Maybe we try to conduct wonderful program. The MMR rate related to the direct and indirect causes among pregnancy women in urban area. Maybe it came from author hemorrhage in the second. For rural area, maybe it's quite similar number, but we can enhance the quality of care. Change in anatomical and physiological occur throughout pregnancy, and this change affects both presentation of certain disease and the treatment. A sound knowledge of this change allows the physician to determine the severity of illness and to instill of appropriate early treatment. Pregnancy induced hemodynamic change which can make patient access challenging. The heart rate, yeah, you can see. The heart rate typically increases throughout pregnancy, and by the end of third trimester, the heart rate is 10 to 20 beats per minute more than the non-pregnancy state. Progesterone-induced smooth muscle relaxation result in increased vascular resistance, which leads to a fall in systolic blood pressure by 2 to 3 mmHg and in diastolic blood pressure by 10 to 15 mmHg during the first 2 trimesters. The blood pressure returned to pre-partum value during the third trimester. There is also a 5 mmHg decrease in central venous pressure by the third trimester. That's why cardiac arrest in pregnancy more common than you think. Maybe sometimes you could not work. You didn't work in maternal and child area. You didn't know that it's very common if we can see this patient stay with unpredictable condition. The change in pregnancy impact on resuscitation, for example, such as respiratory rate or oxygen consumption, it increasingly, and maybe the impact on resuscitation maybe is decreased, buffering capacity, acidosis more rarely, hypoxia and develop more quickly because our physical change during pregnancy. Furthermore, we know more about the reversible cause include 4H and 4T among pregnancy that we should reduce this consequence. And when you take care pregnancy women, you should think more about 4S and 4T, and then we try to reduce the effect of them. Okay, so preeclampsia is very easy. Tamponade, hypoxia. Pregnant women can become hypoxic and more quickly. Cardiac arrest occur when the heart stop beating, probably consequent the heart is. I'm sorry. I'm sorry. What happened? Without oxygen, a person in cardiac arrest is critical death and will remain so unharmed unless they receive treatment immediately. Why high quality CPR can artificially keep the blood pumping and AED machine it needs to restart by the heart. By delivering, what happened to, I'm sorry, who helped, what happened? I didn't share to author, maybe what happened to my slide. Okay, about the adverse obstetric outcome, that's is very easy. That's we should do CPR. Women die as a result of complication during and following pregnancy and childbirth. Most of these complications develop during pregnancy and most are preventable or treatable. Other complications may exist before pregnancy, but are worsened during pregnancy, especially if not managed as part of the women's care. The major complications that account for nearly 75% of all maternal deaths are severe bleeding, infection, high blood pressure, complication, unsafe abortion. Most maternal deaths are preventable at the healthcare solution to prevent or manage complications. For this adverse obstetric outcome, maybe you should think more this called maternal deaths, massive blood transfusion, fetal and neonatal death, shoulder dystocia, or the maybe unexpected ICU and medication is make the problem. We know that maybe you should think more about delay in maternal health, delay to decision to seek care, delay to receiving care, delay to receive adequate care. Therefore, the team management, you should consider trying to enhance the quality of care. They have delay to seek care, receive care, and receive adequate care. Therefore, nurse must early detection, investigation, resuscitation, and management. Okay. Maternal collapse is where the consequence from adverse maternal outcome, where severe respiratory or circulatory distress lead to a sudden change in level of consciousness or cardiac arrest if left untreated during any stage of pregnancy and up to 60 weeks postpartum. Maternal collapse can result from number of causes such as eclampsia, anaphylaxis, or maybe drug or some embolism or something like that. Is it defined as an acute event involve the cardiorespiratory system and or central nervous system, result in a reduced or absent conscious level? The incidence of impact of cardiac arrest in pregnancy is much rarer than maternal in the around 1 in 30,000 maternities, with case fatality rate 42%. Maybe you should think more this is cause maternal collapse, and then you try to reduce the consequence. In your organization about the situation awareness among pregnancy women living complications such as eclampsia, hemorrhage, respiratory failure, and then you action. CPR is very important. That's why you should came to this conference to know about resuscitate among pregnancy women during PIS, labor, and PPS. And tomorrow we will talk about NICU and ICU. And obstetric modified early warning score chart should be used for all women undergoing observation to allow early recognition of the women who become critical ill. Muse score are a simple, quick to use tool based on routine physiological observation. The score of this observation can provide indication of the overall status of patient condition, prompt action, and urgent medication. Medical review when indicates or allow for appropriate management of women as risk of deterioration. This policy therefore apply to all pregnant, labor, and women that can calculate the score. I think if you apply this this instrument, maybe you prompt report to physician or other qualified clinician. When CPR, you could not do alone in the hospital. You should consult to other carrier. Prompt bedside evaluation by physician or other qualified clinician with the ability to active resort in order to initiate emergency diagnosis. And we plan for implement diagnosis workup and post follow-up to senior provider of patient status. Maternal disease is a rare complication of pregnancy. One, the diagnosis of maternal cold book is made in an unresponsive pregnant women. Acute intervention with CPR and basic life support can help maintain maternal circulation while preparing to perform a potential right safe PCR perimodem. Despite the data on poor maternal survival rate after perimodem cesarean section delivery. This chapter will explore the epidemiology, the maternal. You can know the slow of this tip when you have pregnancy women stay with maternal collapse. They should know about how to CPR pregnancy women. For you listen the speaker from Philippines about the update 2020 ASA. But for me, for my responsibility, I present only maternal resuscitate and newborn. This guideline comprehensive revised and for adults, pediatric, neonatal resuscitation, education, science, and system of care topic. They have been developed for resuscitate, provide an ASA instructor to focus on resuscitation science, and you should apply. Yeah. The new adult basic life support. Dr. Ronald also told you that it's some change in this guideline in this year. For the women, they add that maternal cardiac arrest is when during the after childbirth, the mother has stopped breathing. It can caused by exciting breathing, heart failure, heart attack, preeclampsia, birth infection, and amniotic embolism. All of this can result in irregular heart rhythm. This guideline at related pregnancy women about the management of cardiac arrest in pregnancy focus on maternal resuscitation with preparation for early perimodem cesarean section. Maybe sometime who didn't work in pregnancy, you didn't know more about this work. Delivery if necessary to save the infant and improve the chance of successful resuscitation of the mother. Cesarean section during CPR in pregnancy, as well as the potential being fetal for the mother. Maternal cardiac arrest can result in the infant being stillborn. Although doctor will actually attempt a C-section to ensure the baby survive. Studies suggest that guidelines suggest that the infant should be delivered within 5 minutes of maternal cardiac arrest to avoid any neurological problems. Yeah. This is the guideline, this is the chain. Speaker from Philippines also summarize for you. In pregnancy women, we apply adult CPR, but we have some a little bit as more information. This is adult. Yeah. This for the guideline in figure number 9 present the CPR algorithm in hospital. You can consider more that continue BLS or ACLS, high quality CPR like adult CPR. Defibrillation when indicated and other ACLS intervention is such as some medicine, some medical treatment that Donald already mentioned. And then you should consider ethnology of arrest such as perform maternal intervention and perform obstetric intervention. A new cardiac arrest in pregnancy algorithm has been added to address this special case in this finger in the guideline. Resuscitation involves the follow maneuver and intervention with and performs simultaneous, not sequentially. Okay, and you can see return, yes, and this 5 minutes. I already and perimodem cesarean delivery, and then the newborn sent to the neonatal team to receive to take care newborn. The potential ethnology of maternal cardiac arrest include A, B, C, D, E, F, G. This you can study more. From 2020 ASA maternal cardiac arrest recommend some major difference such as the possible cause of maternal arrest is A is mean anesthesia complication, B bleeding, C cardiovascular, D drug, E embolism. Maybe you can see that maybe different. Embolism, F fever, G general non-obstetric cause include S and 4T that I already mentioned, and S it means hypertension. The new guideline mentioned that if there is no return to spontaneous circulation within 5 minutes after cardiac arrest, consider immediate perimortem cesarean section among these women. In the part 4 minutes, this is we can see some different. Author BLS and ACLS recommendation in pregnancy remain same both in 2015 and 20, such as AV defibrillation, LUD, drug, and equipment. This picture summarizes obstetric intervention during CPR. If the uterus is at or above the umbilicus, manual displace the uterine laterally and to the left. To minimize aorta caval compression. Okay, you should do MLUD and remove the detect fetal monitor and prepare perimortem cesarean section. If no return spontaneous circulation in 5 minutes, consider perimortem and neonatal team to receive neonatal. Maybe some people told me mentioned that about the initial high quality chest compression, like doctor, the speaker from Philippines mentioned that at least 100 compression per minute, but not more than 120 compression. Chest at least 5 centimeter, but no more than 6 centimeter. And the ventilation of approximately 350 to 500 milliliters after every 30 compression. It is the same adult CPR. This is the about the continuity in this block. We is a mention on this. We compress 5 to 6 centimeter and 100 to 120, and we waiting recoil, and we stop more than 10 seconds. Defibrillation and drug depend on situation, and we call maternal cardiac arrest. This you should study more when you work these people. About the consider etiology of arrest, perform maternity intervention and perform obstetric intervention. You can consider prepare for perimortem cesarean section. For about the maternal intervention such as IV oxygen management 100% and continue BLS and ACLS. Okay. Sudden cardiac arrest and in 2000 clot is many like I already tell you, but this slide present more the concept of sudden cardiac arrest and death in pregnancy 2020. You can study. This picture manual left uterine displacement. When you help pregnant women during arrest, maybe you use one hand technique or two hand technique, and perform obstetric intervention, provide continue lateral uterine displacement, yes, detect fetal monitor and prepare for perimortem. Yes, you should do this. Okay, I explain more about that. One hand technique and two hand technique. Okay. About the area management, 100% oxygen, avoid excessive ventilation. And if patient receive magnesium sulfate, you should stop magnesium sulfate and you give calcium gluconate and calcium chloride or gluconate for these pregnant women. Some paper recommend that left lateral till 30 degree maybe is help you to do effective CPR and manual left uterine this patient. Okay, this picture you can see about the AED. The intention of this report is not for defibrillation. You can do like non-pregnancy women and you can defibrillation like the guest speaker mentioned that, and you can call other people to help you. Don't touch any AED during shock. You know well, this is the same area to do to apply AED pad in patient. Okay. About the new update about this 2020 AHA, they ask more information that because pregnancy patients are more prone to hypoxia, oxygenation and airway management should be priority during resuscitation from cardiac arrest in pregnancy. Because of potential interfere with maternal resuscitation, fetal monitoring should not be undertaken during cardiac arrest in pregnancy. And they add more information, recommend target temperature management for pregnant women who remain comatose after resuscitation. We should take care temperature also. During target temperature management of the pregnant patient, it's recommended that the fetus be continue monitor for bradycardia as a potential complication, and obstetric and neonatal consult should be sought. While they ask more information about the managing cardiac arrest in pregnancy, because they airway ventilation and oxygenation are particularly important in the setting of pregnancy because of an increase in maternal metabolism, a decrease in functional reverse capacity due to gastrous uterus, and the risk of fetal brain injury from hypoxemia. And evaluation of the fetal heart is not helpful during maternal cardiac arrest, and is may distract from necessary resuscitation element. In the absence of data to the country, pregnant women who survive cardiac arrest should receive target temperature management, such as any other survival will consideration for the status of the fetus that may remain in utero. From the ASA 2020 in Japan, this guideline developed apply for to conduct the maternal cardiopulmonary resuscitation in Japan, and present in this year, 2020. This organization is named Japan Society of Obstetrics and Gynecology, had recently joined the JRC to create an algorithm for maternal CPR and modify the 2020 ASA guideline. Maybe in your country you can, I am not sure that you develop, you modify for your patient in your country, but this organization apply in Japan. JRC by Japan Society of Obstetrics and Gynae, they mention about the left uterine displacement, like the guideline, pyrimidine, exhibit the infusion route of diaphragm, lipid emulsion administration for suspect local anesthesia, and calcium preparation administration for suspect. They review from meta-analysis and review literature to develop the algorithm and apply in Japan. Maybe number one, the birth provide uterine displacement, and then AAD defibrillation IV powerless. You can start. This is maternal advanced life support in Japan. That they modify from 2020 ASA guideline, yeah. And it have detail to apply in pregnant women. This is maternal basic life support. Okay. it have ASA and basic life support. This organization also from Bristol, North Bristol, is it in England? They conduct the cardiopulmonary resuscitation in pregnancy and apply ASA 2020 also. Yes, maybe it's very clear and add information. The best practice point, this guideline present the best practice point that we should consider. Our clinical staff involved in intrapartum care should be familiar with basic life support guideline for pregnancy. Maybe sometime who did not familiar with pregnancy patient, maybe it's not effective well. Basic life support training should be multi-professional and refreshed annually. High quality chest compression should be performed immediate once maternal cardiac arrest is identified and ongoing until return to spontaneous circulation or resuscitation attempt is abandoned. Interruption should be kept to a minimal. Lateral uterine displacement should use to minimize aortocaval compression and maximize cardiac output after 20 weeks gestational. Is add more this detail. Prepare for polymodem as soon as maternal cardiac arrest is declared per within 4 minutes of cardiac arrest. Do not move patient to perform maybe this record keeping should be meticulous, ensuring that team member arrive, team give timing and clear identify and calling 222. In your country, maybe you can call, depend on your number. 222 ensure that maternal cardiac team is required and location to incident identify, ensure access maternity services building of the arrest team, especially out of our senior obstetric anesthesia neonatal staff should be involved as early as possible. This guideline in UK also mentioned prompt material also 4S and 4T. They explain more about the this that we should consider. About the guideline in UK that they also developed from modified from 2020. They are apply BLS algorithm collab women and then they explain about the no pulse or something like that, airway breathing, circulation, disability, and acupuncture side, and then compression, maybe the similar. The follower personnel will receive the maternal cardiac arrest, emergency arrest, including the team, senior coordinating midwife, senior resident obstetrician, senior resident anesthetic that should came together and try to help them. And adult cardiac arrest team, the neonatal resuscitation team should come. Maybe sometime who did not familiar to CPR newborn. We should invite them and you should conduct the maternal code blue in your hospital. About the ALS, they also did organization also conduct the algorithm for this patient. They call 242 and then about the member that should come to in this process, ALS, anaphylaxis, local anesthetic toxicity, high spinal block, that we should invite other people who can do this, come to join at this event. ALS algorithm addition information in defibrillation energy level are the same for the pregnant patient as well as the non-pregnant patient. And they mentioned that LUD, left uterine displacement is very good. It can reduce, it can help pregnant women about cardiac input output, and it can help. It's good for CPR. Okay, and about the polymorphism, if second stage, okay. Maybe we can collaborative vagina if it's very fast more than polymorphism. Okay, depend on the pregnancy women. Successful resuscitation from cardiac arrest is likely to be successful without delivery of the baby. This is due to the combination aortic valve compression and cardiac output demand pregnant uterine. Polymortem cesarean section should be initiated as soon as initial resuscitation measure are unsuccessful within 4 minutes, and we should establish within 5 minutes. This guideline also mention that, and you can see. Outpatient cardiac arrest. Sometimes we make pregnancy women arrest outside the hospitals. In case of cardiac arrest outside of the main hospital setting, such at home or maybe some unit, staff should commence CPR dispatch of uterus to the left and rapid transfer patient to the hospital via emergency services. In theory, a pre-alert to maternal cardiac arrest team should be placed so that perimortem cesarean section operation as soon as after arrival. About the massive hemorrhage and neonatal team, a cordless massive obstetric should come to hemorrhage call should be activated at the time of the decision to proceed to fetal delivery. The uterus is likely to be atonic and return to spontaneous circulation may precipitate abnormal coagulopathy from major hemorrhage. Okay, and future care, maybe we talk tomorrow. And if unsuccessful resuscitation, maybe about the maternal death guideline, you should follow maternal death guideline. Leave line and you should leave line endotracheal tube and other invasive medical device in situ unit as well from coroner sort. Okay, and you conduct team to make the family member of these women. And about the ALS algorithm addition information, this guideline also mention many detail of many aspects. You can study more. Next topic, that's major new and updates recommendation in newborn. Newborn may be some part of pediatric CPR. It have infant and newborn together, and you can apply such as this checklist, cardiac checklist. This is the chain of CPR, ISCA and OSCA among pediatric patients. For me today, I propose only newborn. This is 2020 American Heart Association about newborn algorithm. Antenatal counseling team briefing and equipment checking. And then you should know that some pregnant women have under stress, under pressure, maybe the newborn have a problem also. You should consult the team, and then after birth you follow the guideline. And then they mention about the target preductal SPO after birth, something that. About the major new update and recommendation in 2020, they asked for infant and children with proud but absent or inadequate respiratory effort. It is reasonable to give one beat every 2 to 3 seconds, or maybe 20 to 30 beats per minute. In this 2010, okay, a little bit different. Okay. About the change to assist ventilation rate during CPR with an advanced airway. When perform CPR in infant, follow this. Accounting for age and clinical condition rate exceed this recommendation may compromise hemodynamic. In 2010, they didn't mention the more detail like 2020.
My apologies, Prof. You have 5 minutes.
Okay.
Left.
About the major new update recommendation, they mentioned about the CAP, ETT, coil pressure, and evaluation support cardiac arrest survival. And they recommend that pediatric cardiac arrest survival be evaluated for rehabilitation services, like speaker from Malaysia research. And it's reasonable to refer pediatric cardiac arrest survival to ongoing neurologic evaluation for at least first year after cardiac arrest. And about the choice of vasopressin also mention the new information for infant. Oh yes, you can study. Yeah. About the cup, they mention the cup of ET2 among newborn that we should choose. And anticipation resuscitation need. Every birth should be attended by at least one person who can perform initial step of newborn resuscitation and initiates PPV and hold responsibility and care of newborn. Temperature. In 2020, ask more about the temperature management for newly born infant and clear the air via meconium is present. And Smart Kula 2020 about the terminate resuscitation. In newborn baby receive resuscitation if there is no heart rate and all the step of resuscitation have been performed. Cessation or resuscitation is maybe around 20 minutes enough, and maybe some situation maybe depend on cases and human and system perform. Okay, this is from this organization that they conduct the transition care and resuscitation newborn infant in delivery room. You can apply in your organization. And about the more corticosteroid administration and hemorrhagic shock. And this is the summary of the life support in newborn that you can study. Yet I summarize. Yeah, this is the picture that I also present to you that you can apply in your about the material during CPR, about oxygen saturation and cord clamping, and maybe mat with soft cushion and maybe ventilation. Okay. Umbilical cut and maybe this. Chest compression, maybe you know well to time technique who work in this. This is the neonatal resuscitation 8 edition also. It applied from ASA 20 also. You can study more. Maybe this is the guideline from 8 edition algorithm. Okay, you can read. And maybe it's a little bit change that before about 8 edition, the flow pre-birth question, GA, amniotic clear, additional risk factor, and umbilical cord management plan. For initial step, warm, dry, stimulation, position, airway, suction if needed, and electronic cardiac monitor, IV pulse, and explain time frame cessation. Okay, 20 minutes. In the part that maybe after 10 minutes. Okay, and we should do. This is NRP for non-neonatologists. And they teach you about the soft mask for student, for newborn. Early resuscitation and advanced resuscitation. This guideline also present and suggest you to do for newborn. This is another guideline after 2020 from European Resuscitation Council guideline. In 2020, maybe is modified ASA 20 also, and this is the guideline from this organization. And they present the antepartum factor and interpartum factor that maybe a little bit different, and present from preterm baby, intervention for preterm baby also. Is recommendation for nurses to apply and summary change a little bit. Okay, guideline. And this top message from this organization: delay cord clamping, optimize condition, effective thermal care, asset breathing and heart rate status, and simple step support airway and chest compression. Only one effective ventilations. Okay, thank you very much. Okay, thank you.
Okay, thank you, Prof.
Yeah.
Your presentation make us interested, and there are many questions for you. The first question
Okay,
from
Yeah.
Yeah. The first question from Novi Pertiwi AMD Cup. She asked, cardiac arrest in pregnant women with active bleeding. Do it need to do a CPR?
Yeah, CPR is the first, and then about the stop the cause of hemorrhage, you can do together. CPR one person, and then you can manage about uterine atony and other factor of hemorrhage. Okay.
It's the meaning the nurse or the helper more than one person.
Yes. Normally,
Okay.
we CPR in the hospital, but in outpatient may be different if you found patient alone. Yeah.
Oh, okay.
Yeah.
Thank you. Oh, there are Bapak Adelino Nuno, Mr. Adelino Nuno. Okay, any question for you? You can directly to Prof. Pratuma Ritko. Please, Mr. Adelino.
Yes.
Hello,
Yes.
Doctor.
Sawadika. Yeah. Hello.
Sawadika. Greeting from Timor-Leste, Doctor.
Yeah.
Nice to meet you.
Nice to meet you too. Okay, keep in touch. Okay.
Okay, sure. My question is that, is it allowed to do CPR for women or mother with TBC, since the heart is already, the thorax is already, a problem, and then it's allowed to have a CPR for mother with tuberculosis, TBC?
Tuberculosis.
Yeah.
Yes, we can
Is it
do.
allowed?
Yes, yeah, we can do, because the CPR is the first important intervention that we should apply or patient. Yeah, if they have a cardiac arrest. Yeah.
Okay.
You understand?
Because
we can do. Yeah, we can apply. Yeah.
Okay. Because my imagination, the thorax is already a problem, and then we do the press, and then it might be a problem, adding a much problem to the lung.
No, because we need circulation, but circulation to help them to survive. And then about tuberculosis, and maybe sometimes bone, factor bone, maybe it's not less important when compare circulation, but circulation to help them.
Yeah. And since you have a specialization in AIDS, so can you tell me a little bit, what is the procedure, specific guideline for maternal with HIV, AIDS, when we do the CPR? Is there any guideline, specific guideline?
No CPR guideline among HIV patients, but when we do CPR, we must protect ourselves. We are expert and we know how to protect themselves. You can wear glove or mask, something like that, and you could not touch blood directly. That's why you must present your protect yourself well. Yeah.
Kapun ka.
Kapun ka. Thank you. Please come to Thailand.
Kapun ka.
We waiting you in Thailand. I saw some increased cardiac arrest in maternal. Can we use AED for the fifth? I already told you that we can use AED. Yes, okay. It's like the adult patient, but we have some interventions such as left uterine replacement and polymorphs, more than adult, general adult patient. Okay.
Okay. Thank you, Prof. I think it's oh, your time is up. So
yes,
thank you so much. You come here, and we meet again tomorrow.
Okay. Sawadika. Okay. I will tell.
Sawadika.
Yes, I will attend next session also. Okay. Bye-bye.
Okay. Thank you so much, Prof. Okay. I can. I'm sorry for Apriyadi Eskep from RSUD Waluyo Jati because the time is up. So maybe tomorrow we can ask to Prof. Pratama about your question. Okay? Okay. Now I will read the conclusion from the presenter, third presenter, about the update cardiac trauma life support for maternal and neonatal. Okay. Cardiac arrest in maternal or neonatal, it's have to treatment as soon as possible or have to treatment immediate. This is nurse have the important role. For example, early detection, early investigation, early resuscitation, and the nurse role have to be one team management. For example, for treatment immediate in maternal is a maternal collapse. For example, in the case of eclampsia or preeclampsia, eclampsia and preeclampsia, anaphylaxis and cardiac causes arrhythmias and respiratory failure. There is need a treatment as soon as possible. It can undergoing observation with MEOWS or maternal early obstetric warning score. In management of cardiac arrest and pregnancy, focus on maternal resuscitation. According to American Heart Association in 2020, cardiac arrest and pregnancy in hospital perform maternal and perform obstetric intervention. Perform maternal intervention is like perform airway management and then 100% oxygen and place IV above diaphragm and so on. And the important thing, moment. Best practice point, according to Prof. Pratuma, clinical staff involved in intrapartum have to familiar with pregnant guideline, basic life support training, high quality chest compression, and left lateral uterine displacement should be used to minimize aortocaval compression and maximize cardiac output after 20-week gestation. It's the important thing from Prof. Pratuma. Jadi untuk update cardiac and trauma life support for maternal and neonatal, yang terpenting di sini untuk orang hamil yang mengalami cardiac arrest itu harus dilakukan treatment sedini mungkin, as soon as possible atau sesegera mungkin ya. Contohnya hal ini terjadi pada maternal yang mengalami kolaps ya. Contohnya kasus apa seperti eklampsia, preeklampsia berat, anafilaksis, kardiak, kasus-kasus kardiak, kegagalan nafas dan sebagainya ya. Hal itu semua dapat dideteksi melalui undergoing observation of namanya MEOWS atau maternal early obstetric warning score. Ini yang digunakan untuk melihat kegawatan daripada maternal tersebut yang biasa dipakai di Thailand ya. Di sini dalam update cardiac trauma life support for maternal and neonatal ini peran perawat sangatlah penting. Terutama di sini adalah untuk deteksi awal, investigasi lebih awal, resusitasi lebih awal, dan di sana terbentuk satu tim manajemen yang solid ya. Kemudian untuk manajemen of cardiac arrest in pregnancy itu yang terutama adalah berfokus pada resusitasi maternal. Ya, menurut AHA 2020 atau American Heart Association 2020, cardiac arrest in pregnancy di hospital itu di sini yang terpenting adalah perform maternal intervensi dan perform obstetric intervensi, ya. Tapi di sini yang terpenting pula dari poin-poin yang best practice ini, yang pertama adalah semua staf yang terlibat dalam intrapartum, ya, perawatan intrapartum itu semua harus familiar terhadap guideline untuk melakukan resusitasi. Karena apa? Dikatakan bahwa setiap tahun ini harus update gitu, ya. Kemudian basic life support training itu semua harus sudah melakukan atau sudah mendapat pendidikan mengenai basic life support itu. Kemudian yang terpenting untuk high quality chest compression ini harus dilakukan dengan benar, ya, agar hasilnya juga bagus gitu. Kemudian spesifikasi daripada untuk CPR orang hamil ini posisinya harus lateral, ya. Posisinya harus left lateral urine displacement should be used to minimize, untuk meminimalkan aorta caval compression. Itu adalah hal yang terpenting dari apa yang telah disampaikan oleh Prof. Pratuma. Oke. Now we are continue to for a speaker. Halo Pak Welas.
Halo, selamat sore. Assalamualaikum. Salam sehat.
Salam sehat selalu Pak. Waalaikumsalam warahmatullahi wabarakatuh. Pak Welas sudah ada di sana. No, I will brief CV curriculum vitae of Mr. Welas. As Coordinator Nursing Services in Fatmawati Hospital, Jakarta, Indonesia. Background education in 2003, a bachelor graduate from Bachelor of Nursing from University of Indonesia, and 2004 passed from nurse profession from University of Indonesia, and in 2011 Master of Nursing from University of Indonesia, and 2011 Medical Surgical Nursing Specialist from University of Indonesia. Okay, and work experience in October 23 until April 2016 as Coordinator of Nursing Services in Emergency Department, Fatmawati Hospital, Jakarta, Indonesia. And from April 2016 until May 2017, Clinical Nurse Grade 4 in Emergency Department, Fatmawati Hospital, Jakarta, Indonesia. And from May 2017 until July 2019, Head of Quality of the Nursing Profession Fatmawati Hospital. And July 2019 until present as Coordinator of Nursing Services in Professor Dr. Sularto Building in Fatmawati Hospital. For the experience in organization, no, he to be head of the Emergency Nurse Association from 2018 until now. Okay, Pak Welas, you have 40 minutes to present your materi, your subject, and I will remind you if 5 minutes left. And no, please deliver your speech, sir. Silahkan Pak Welas.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Izin suara saya jelas terdengar di visi teman-teman.
Sangat jelas, Pak. Very clear.
Oke, terima kasih. Selamat sore, salam sehat untuk teman-teman semuanya. Sebelumnya apresiasi buat Pusat Pelatihan Kesehatan Madani yang untuk kesekian kalinya saya diberikan kesempatan untuk berbagi informasi, berbagi pengalaman, bagaimana penata laksanaan sore ini terkait update basic cardiac life support. Nah, materi ini saya yakin materi yang sehari-hari teman-teman lakukan, jadi ini hanya share update-nya. Saya yakin teman-teman juga sudah mendapatkan paparan materi ini, baik di pembelajaran maupun ketika update di pelayanan masing-masing. Ya. Tadi sudah diperkenalkan, nama saya Welas Rianto, saya sehari-hari ada di Rumah Sakit Fatmawati. Teman-teman bila berkenan untuk diskusi bisa ke HP saya 081 763 07707. Ketika kita bicara cardiac arrest, tentu kondisi ini sangat sepakat dan sering kita dengar bahwa kondisi gawat darurat itu bisa terjadi kapan saja, di mana saja, dan bisa menimpa siapa saja. Sehingga sebagai tenaga kesehatan, dalam hal ini kita sebagai SDM perawat, tentunya dituntut untuk bisa memberikan pelayanan dalam kondisi kegawat daruratan cardiac arrest ini sesegera mungkin. Atau bahkan juga kita bisa memberikan informasi, melatih masyarakat awam untuk bisa juga melakukan pertolongan pertama pada kondisi cardiac arrest. Kenapa? Karena kondisi cardiac arrest tadi, kalau kita lihat di kejadian sehari-hari, itu bisa terjadi di mana saja, kapan saja, dan bisa menimpa siapa saja. Seperti gambaran video berikut ini.
إنه الموت لا يعرف كبيرا ولا صغيرا ولا مسلما ولا كافرا ولا حرا ولا عبدا ولا رئيسا ولا مرؤوسا ولا ملكا ولا مملوكا. قل للطبيب تخطفت يد الردى يا شافي الأمراض من أرداك. إنه الموت الذي لا يحتجب عنه بالحجاب ولا يمتنع عنه بالعساكر. إنه الموت الذي يدركنا ولو تحصنا منه في بروج مشيدة. إنه الموت قد لا تبتلى قبله بمرض، وقد لا يقع لك قصة تدل على قربه إليك، لكنه الموت يهجم عليك دون استئذان. الملوك يموتون، والرؤساء يموتون، والتجار يموتون، والفقراء يموتون.
Itu adalah gambaran yang mungkin kita lihat ada di depan kita, atau mungkin masyarakat yang ada di sekeliling korban tadi adalah orang pertama yang menemukan kondisi kegawat daruratan pada kasus-kasus cardiac arrest. Kalau lihat video pembelajaran tadi, tentunya bagaimana orang yang ada di sekeliling tempat kejadian tadi bisa memberikan pelayanan yang terbaik. Bagaimana bisa memberikan resusitasi jantung yang baru dengan high quality CPR, seperti tadi yang sudah disampaikan. Nah, pokok permasalahan yang kita alami di masyarakat kita adalah bahwa masyarakat kita belum terpaparkan kondisi-kondisi seperti ini. Ini salah satu tugas kita sebagai tenaga kesehatan untuk bisa berbagi ilmu, berbagi pengalaman, berbagi informasi terhadap penguatan masyarakat kita untuk bisa memberikan pertolongan pada kondisi-kondisi kegawat daruratan. Bagaimana kita mendidik masyarakat kita memberikan pertolongan pada kondisi kegawat daruratan, memberikan pertolongan pertama pada kasus-kasus kecelakaan. Justru jangan terjadi yang sebaliknya, yang terjadi kecelakaan pada pertolongan pertama. Kenapa? Karena masyarakat kita masih awam. Belum ada penguatan dari kita-kita yang paham tentang pelayanan kondisi kegawat daruratan, dan ini adalah tantangan kita bersama bagaimana kita memberikan edukasi kepada masyarakat tadi. Nah, tentunya ini menjadi hal yang perlu kita cermati untuk kesekian kalinya, bahwa kondisi-kondisi seperti tadi bisa segera kita lakukan penata laksanaan yang adekuat ketika pembelajaran yang kita sampaikan kepada masyarakat awam tadi bisa terlaksana dengan baik. Melihat beberapa kasus yang tadi kami paparkan, tentunya ini adalah hal yang menjadi buah pikiran kita untuk bisa memberikan penguatan kepada masyarakat, agar masyarakat juga ikut berkontribusi, bertanggung jawab, memberikan pelayanan yang terbaik pada kondisi kegawat daruratan. Di berbagai kesempatan penelitian yang coba kita baca, bahwa di sana dinyatakan bahwa 95% pasien henti jantung itu meninggal sebelum tiba di rumah sakit. Angka ini bisa kita turunkan ketika masyarakat awam memahami, mengetahui, dan bisa melakukan pertolongan pertama pada kondisi kegawat daruratan. Teman-teman bisa bayangkan ketika dari yang hadir kali ini ada kurang lebih 658 sejawat kita. Besok hari Minggu ngadain kegiatan di lingkungan masing-masing. Ngumpulin RT, ngumpulin remaja masjidnya, mengumpulin Karang Taruna, kita informasikan bagaimana sih melakukan BHD. Setiap kita bisa mengumpulkan 5-10 orang. Sudah berapa ribu masyarakat kita edukasi untuk bisa melakukan bantuan hidup dasar. Dan kematian dapat dihindarkan jika makin banyak orang yang mampu melakukan resusitasi jantung dan paru. Di beberapa penelitian juga dikatakan bahwa kemungkinan hidup seseorang akan berkurang 10% setiap menitnya ketika pertolongan tidak segera kita lakukan. Sehingga makin cepat kita melakukan resusitasi jantung dan paru, hasilnya akan lebih baik ketika kita terlambat melakukan resusitasi jantung dan paru. Fakta menyatakan bahwa ketika terjadi cardiac arrest, maka suplai ke oksigen ke otak akan berkurang. 3-8 menit otak tidak ada suplai oksigen, maka akan terjadi kematian sel-sel di otak. Dan inilah yang mungkin dampak yang timbul ketika seseorang terjadi penurunan kesadaran, suplai oksigen yang tidak adekuat, pasti ada gejala sisa pada kondisi-kondisi di mana terjadi hipoksia. Nah, indikasi dan tujuan CPR atau BHD tentunya ketika kita melihat pasien-pasien yang mengalami henti jantung, henti napas, atau kita melihat kondisi-kondisi pasien yang pernapasannya berhenti atau pernapasannya gasping. Itu adalah tindakan yang harus segera kita lakukan agar pasien terhindar dari kondisi yang mematikan. Dan tentunya tujuannya adalah untuk mencegah berhentinya sirkulasi ataupun berhentinya pernapasan. Tindakan yang kita lakukan tentunya dengan memberikan bantuan eksternal terhadap sirkulasi dan ventilasi. Ini adalah yang kita lakukan sedini mungkin ketika kita mendapatkan pasien-pasien dalam kondisi cardiac arrest. Nah, penanganan cardiac arrest sebenarnya sudah berkembang dari tahun ke tahun. Ya, kalau kita bicara resusitasi jantung dan paru, kita mengenal chain of survival, rantai kehidupan. Di tahun 2000 kita mengenal bagaimana ketika ada kondisi kegawat daruratan kita harus segera meminta bantuan, segera melakukan CVR, segera melakukan defibrilisasi, dan segera mungkin tindakan yang sifatnya advance terhadap kondisi-kondisi cardiac arrest. Berkembang di tahun 2005, ya, bagaimana pengenalan kondisi-kondisi cardiac arrest, bagaimana sesegera mungkin kita melakukan early CVR, early defibrilisasi, dan bagaimana pasca resusitasi care-nya. Di tahun 2010 juga berkembang. Ketika ada kondisi kegawat daruratan cardiac arrest, bagaimana pasien ini sesegera mungkin untuk penolongnya call for help, minta bantuan kepada tim yang lebih advance, dan sesegera mungkin melakukan bantuan hidup dasar dengan chest compression. Dilanjutkan defibrilisasi, tim yang advance datang, tentunya ketika sudah advance yang datang, penata laksanaan post cardiac arrest-nya juga harus diperhatikan. Dan ini berkembang terus-menerus hingga di tahun 2015 ada pembaharuan rantai kelangsungan kehidupan chain of survival, di mana rantai kelangsungan hidup itu dibedakan antara pasien yang mengalami serangan jantung di intrahospital, atau kita kenal dengan ICA, intrahospital cardiac arrest, dan out hospital cardiac arrest. Ini dikenalkan di tahun 2015. Nah, di tahun 2015, kalau kita lihat rantai kehidupan antara ICA dan OCA, yang pertama dikenalkan adalah intrahospital, bagaimana pengawasan dan pencegahan. Kalau tadi di dalam paparan 3 materi di depan bahwa pengawasan dan pencegahan itu hal yang harus dilakukan di intrahospital, tentunya dengan melakukan monitoring yang adekuat terhadap pasien kelolaan kita. Jangan sampai juga ketika kita bertugas di pelayanan, laporan ke dokter jaga melaporkan, dok izin laporan, pasien Tuan B 25 tahun pasca kraniotomi tiba-tiba apnu. Nggak ada pasien tiba-tiba apnu. Pasti ada degradasinya, penurunan kondisi pasien dengan kita melakukan monitoring, atau sekarang yang kita kenal dengan EWSS, Early Warning Score System. Ketika itu kita lakukan, pengawasan dan pencegahan bisa kita lakukan. Bagaimana di out hospital cardiac arrest? Pengenalan dan pengaktifan sistem tanggap darurat. Bagaimana masyarakat awam terfasilitasi, terkenalkan ketika ada kondisi gawat darurat, minta tolongnya kemana. Jangan sampai juga lebih familiar GoFood, hafal nomor telepon GoFood daripada nomor telepon gawat darurat. Itu yang bahaya. Jangan sampai juga harga nyawa lebih murah dibandingkan harga apa itu, paha ayam ya, KFC gitu. Itu nggak benar itu. Bagaimana kita juga bertanggung jawab mengedukasi masyarakat bagaimana dia bisa kenal dan aktif ketika ada kondisi kegawat daruratan, agar pasien-pasien yang tadi terjadi cardiac arrest di pra rumah sakit juga mendapatkan pelayanan yang adekuat. Nah, update di tahun 2020, kalau masih berbicara pada intrahospital cardiac arrest dan out hospital cardiac arrest, di tahun 2020 di sisi akhir dari penata laksanaan cardiac arrest adalah bagaimana menjadi fokus rantai ke-6 dari kondisi-kondisi pasien yang sudah dilakukan penata laksanaan, yaitu pemulihan. Sebagai tenaga kesehatan, baik yang ada di intrahospital maupun di out hospital, pra rumah sakit, harus memperhatikan pasien-pasien yang sudah pulih terhadap kondisi kegawat daruratan ketika cardiac arrest dengan melakukan pemulihan recovery, melakukan monitoring yang adekuat untuk menjamin bahwa kondisi pasien ini tidak terjadi perburukan yang kedua kalinya. Nah, kalau di OCHA kita kenal aktivasi respon gawat darurat, CPR kualitas tinggi, defibrilisasi, sehingga di out hospital kalau kita perhatikan di tempat-tempat umum, ya, di bandara, di stasiun kereta api, pemerintah sudah memfasilitasi dengan adanya AED. Itu adalah salah satu kelengkapan yang bisa kita gunakan ketika ada kondisi kegawatdaruratan kardiak arrest di pra rumah sakit, apalagi di intra rumah sakit. Idealnya lingkungan-lingkungan yang ada di dalam rumah sakit juga tersediakan alat defibrilisasi, jangan sampai kalah dengan yang terjadi di out hospital cardiac arrest. Kalau di intra hospital cardiac arrest, tadi pengenalan awal dan pencegahan itu fokus yang harus dikuatkan. Bagaimana tadi disampaikan early warning score system, baik pada pasien-pasien dewasa, pasien-pasien anak, pasien-pasien maternitas. Banyak pendekatan yang bisa kita gunakan untuk melakukan pengenalan gejala awal kondisi perburukan atau bahkan kita mencegah perburukan kondisi cardiac arrest. Ya. Di dalam intrahospital cardiac arrest pun juga tetap harus melakukan high quality CPR. Defibrilisasi juga harus ditentukan. Yang terakhir adalah pemulihan menjadi fokus di AHA 2020. Nah, di dalam pelaksanaan sekuen bantuan hidup dasar, resusitasi jantung dan paru, saya yakin ini sejawat saya juga sudah familiar dengan manajemen airway breathing sirkulasi, sekuen BHD di tahun 1966 sampai sekitar 2010, sehingga di tahun 2010 sampai sekarang kita menggunakan pendekatan CAB. Ya, kita meninggalkan airway breathing sirkulasi, tetapi kita akan meningkatkan bagaimana kompresi airway breathing menjadi langkah awal yang harus dilakukan ketika ada kondisi-kondisi kegawat daruratan. Kompresi di sini adalah bagaimana kita merangsang kembali jantung agar segera berdenyut dengan melakukan kompresi. Dengan memahami ada tidaknya fungsi denyutan jantung. Ini adalah perubahan sekuen AHA di tahun 2010 yang kita pakai hingga sekarang. Dan langkah-langkah pelaksanaan CVR tentunya juga sudah familiar di benak kita semuanya. Bagaimana sebelum kita melakukan resusitasi jantung dan paru, kita juga harus memperhatikan safety kita, safety tenaga kesehatan, safety lingkungan, safety terhadap pasien sendiri. Selanjutnya melakukan cek respon. Ada tidak pasien ini betul-betul dalam kondisi cardiac arrest? Kalau pasien betul dalam kondisi cardiac arrest, bagaimana kita teriak minta bantuan? Bagaimana kalau bantuan itu kita temukan pasien yang ada di out hospital cardiac arrest, di luar rumah sakit? Bagaimana kalau di dalam rumah sakit? Nanti kita akan diskusikan di belakang. Berikutnya adalah memberikan bantuan sirkulasi, buka airway, bantuan breathing. Hal inilah yang harus kita lakukan, bahwa langkah-langkah CPR tadi, ya, pada kondisi bahaya kita memastikan keamanan kita, keamanan pasien, keamanan lingkungan. Bagaimana memastikan bahwa pasien ini betul-betul bahwa dia kondisi cardiac arrest. Jangan juga pasien lagi tidur pules karena kita tidak memahami bagaimana kondisi yang nyata bahwa pasien ini cardiac arrest, langsung aja resusitasi. Kata Pak Ulas, makin cepat makin bagus. Ya, nggak charge respon, langsung aja RJP. Nggak taunya pasiennya tidur pules tuh di bawah pohon. Kenapa? Karena cek respon kita nggak adekuat. Ketika respon pasien betul-betul dia kondisi cardiac arrest, bagaimana kita minta bantuan? Shout for help, teriak minta bantuan. Dengan tentunya sebelum kita melakukan resusitasi jantung dan paru, pastikan cek nadi karotisnya betul ada atau betul nadi karotisnya nggak teraba. Buka jalan napas, mau head chin lip, mau jaw thrust, tergantung dari kondisi real yang ketika pasien saat kita temukan. Berikutnya adalah memberikan bantuan napas, dilanjutkan nanti dengan sekuen resusitasi jantung dan paru. Nah, di AHA 2020 tentunya ketika kita mendapatkan pasien-pasien dengan cardiac arrest, yang harus kita lakukan adalah memastikan dulu, betulkah pasien ini cardiac arrest atau tidak. Itulah pentingnya ketika menemukan pasien-pasien dalam kondisi cardiac arrest, ada AED. Kalau ada AED, kita memastikan dia betul-betul cardiac arrest atau tidak. Atau bahkan kalau kita tenaga kesehatan bisa cek nadi karotis. Itu adalah yang bisa kita lakukan. Begitu juga pada kasus-kasus henti jantung pada anak. Ini menjadi perhatian kita bagaimana resusitasi jantung dan paru pada anak dan dewasa. Tentunya tidak ada perbedaan yang signifikan. Tentunya adalah rasio dari kompresi yang kita lakukan kepada pasien anak maupun pasien dewasa. Nah, tadi dikatakan bahwa ketika kita mendapatkan pasien kondisi cardiac arrest, secepat mungkin kita melakukan resusitasi jantung dan paru, maka peluang keberhasilannya relatif tinggi. 1 menit pertama itu potensial keberhasilnya bisa dikatakan 98%. 3 menit terlambat 50%, 10 menit terlambat kita tinggal 1% kemungkinan itu akan berhasil. Sehingga dari penelitian yang dilakukan di AHA bahwa semakin cepat kita melakukan resusitasi jantung dan paru di menit-menit awal, maka angka harapan hidup, persentase angkatan hidup relatif tinggi. Tetapi ketika kita terlambat melakukan resusitasi jantung dan paru, maka tingkat keberhasilannya juga semakin rendah. Inilah pentingnya tadi saya katakan, makin cepat makin bagus kita melakukan resusitasi jantung dan paru. Sehingga edukasi kepada masyarakat penting sekali, karena masyarakat adalah orang pertama kali yang menemukan pasien-pasien dalam kondisi cardiac arrest dibandingkan kita. Sekuen BHD tentunya kita harus memastikan dulu apakah pasien ini betul-betul cardiac arrest atau tidak. Yang pasti kita cek respon. Tidak ada respon, apa yang kita lakukan? Minta pertolongan, solve POHE. Berikutnya adalah cek nadi dan cek napas secara simultan. Tidak boleh lebih dari 10 detik. Ketika ragu-ragu, anggap saja pasiennya cardiac arrest. Ya. Untuk memberikan keamanan kepada pasien. Ketika nadi tidak ada, napas tidak ada, lakukan kompresi. 30 kompresi, 2 ventilasi selama 2 menit. Tetapi ketika dilakukan pengecekan, ya, nadi ada tapi napas tidak ada, berikan bantuan ventilasi selama 2 menit. Ya, ketika dicek nadi, cek napas, napas ada, nadi ada, ya posisi recovery, jadi pasiennya aman. Nggak ada masalah. Nah, yang jadi kendala di kita, di masyarakat kita adalah bagaimana kita mendidik masyarakat kita memahami 3 sekuen ini. Ya, bisa melakukan kondisi-kondisi pada cardiac arrest. Nah, langkah pertama yang diperhatikan tadi adalah kita harus aman. Aman apa? Aman pasien, aman penolong, aman lingkungan. Nah, di masa pandemi COVID ini menjadi perhatian kita. Alhamdulillah angkanya sudah mulai turun ya. Kita sudah ditarik pandeminya menjadi endemi. Nah, ini juga tetap hati-hati, tetap waspada bagaimana keamanan itu masih melekat pada diri kita ketika kita melakukan pertolongan pada kondisi kegawat-daruratan cardiac arrest. Aman penolong, amankan pasien. Ketika ada pasien trauma di tengah jalan, ya geser dulu. Geser dulu ke pinggir jalan. Amankan lingkungan juga. Pada kondisi-kondisi yang seperti ini, amankan lingkungan. Kalau ada di intrahospital, jangan lupa juga. Kalau masih menggunakan tabung, tabungnya ya amankan. Jangan sampai tabungnya nanti ketika kita ya menarik oksigennya, jatuh, ya, atau di atas berangkar, berangkarnya belum dikunci, ya, berangkar giginya dikunci. Itu adalah salah satu bagaimana kita memastikan keamanan ketika sebelum kita bekerja. Cek respon. Tepuk bahu pasien, panggil nama pasien kalau kenal, ya. Atau kita bisa juga melihat sambil tepuk bahu, hati-hati. Lakukan pengkajian secara seksama. Ada nggak tanda-tanda jejak di atas klavikula ke atas? Ya. Ketika kita menata pasien seperti ini, ada beberapa yang bisa kita temukan. Kita sambil melihat kondisi pasien, apakah pasien ini juga ada tanda-tanda jejas di atas klavikula ke atas. Ini mengindikasikan kalau ada jejas klavikula ke atas, pasiennya ini kemungkinan dengan brain traumatic injury, cedera kepala, kemungkinan suspek fraktur servikal. Hubungannya apa? Hubungannya hati-hati nanti ketika kita membuka jalan napas. Ya, nggak boleh head tilt chin lip, yang boleh adalah teknik membuka jalan napas dengan teknik jaw thrust. Nah, berikutnya adalah teriak minta pertolongan. Di AHA 2020 direkomendasikan kita menggunakan handphone untuk minta tolong kepada tim kesehatan yang ada di luar rumah sakit. Itulah pentingnya kita hafal tahu nomor telepon emergency, ya, nomor telepon gawat darurat di lokasi kita masing-masing. Ya. 119. Ya. Itu akan terhubung langsung dengan sentral komunikasi gawat darurat 119 di Kementerian Kesehatan yang tentunya nanti akan di device ke lokasi ketika kita menyampaikan permintaan pertolongan. Dan salah satu yang harus dilakukan adalah ketika di lokasi-lokasi misalnya bandara, terminal, sebagian besar sudah ada AED, jangan lupa juga teriak untuk bisa dibawakan AED untuk memberikan pertolongan pada kondisi kegawat daruratan. Berikutnya adalah sirkulasi, pastikan ada tidaknya nadi korotis, yaitu di antara 2-3 cm di samping trakea. Nah, untuk orang awam ini tidak direkomendasikan di AHA 2020. Orang awam rekomendasinya adalah ketika sudah mendapatkan bahwa pasiennya ini kelihatannya dadanya nggak kembang-kempis, ya tugasnya masyarakat awam hanya hand only CPR, hanya melakukan kompresi jantung, ya kecepatannya 100 sampai 120 kali per menit, dilakukan sampai dengan tim kesehatan yang advance yang tadi teriak minta bantuan itu datang. Nah, ketika kita melakukan kompresi tentunya akan menjadi lebih baik ketika posisi pasien, posisi penolong mampu memberikan tindakan yang maksimal. Kalau kita ada di pra rumah sakit, posisikan pasien supine di tempat yang datar dan keras, posisi kita berlutut di samping antara bahu pasien untuk memberikan pertolongan. Ya. Tentunya titik tekan kompresi juga menjadi hal yang harus mendapat perhatian. Bagaimana kita memberikan kompresi. Ya. Kompresi yang baik adalah kompresi ketika kekuatan ada di bahu. Posisi tangan tegak lurus, ya, dengan sternum, kekuatan di bahu, engsel ada di sendi panggul. Ini akan memberikan adekuasi CPR kompresi yang cukup baik. Dan kedalamannya untuk dewasa 2-2,4 inci atau sekitar 5-6 cm. Rasio antara kompresi dan ventilasi untuk orang dewasa baik 1 maupun 2 penolong sama. 30 kompresi, 2 ventilasi. Untuk bayi dan anak kedalamannya adalah sepertiga dari diameter apilateral dari torak. Rasio kompresi kedalamannya, ya, kalau penolongnya 1 orang 30 kompresi 2 ventilasi, tetapi kalau 2 penolong 15 kompresi 2 ventilasi. Nah, hal yang harus diperhatikan adalah titik tumpu. Titik tumpu menjadi high quality CPR yang harus diperhatikan. Jangan sampai posisi titik tumpu ini tidak adekuat. Dampaknya apa? Dampak dari yang kompresi kita berikan juga tidak maksimal. Ya, titik tumpu ada di mid sternum. Ya. Posisi kita tegak lurus, engsel ada di panggul. Ini memberikan kompresi yang betul-betul adekuat. Nah, setelah memberikan kompresi tentunya bantuan breathing. Bantuan breathing akan maksimal ketika jalan napasnya terbuka. Tadi ketika kita melakukan pengkajian pasiennya ini napas atau tidak, nadi kardiologinya terlambat atau tidak, kita tadi melihat bagaimana kondisi di bagian wajah pasien, ada jejas atau tidak. Ketika pasien tidak ada riwayat trauma, tentunya aman untuk kita melakukan teknik buka jalan napas head-tilt chin-lift. Tetapi ada kondisi-kondisi tertentu, ada trauma servikal, ini tidak boleh dilakukan. Head-tilt chin-lift harus dengan membuka jalan napas dengan jaw thrust. Nah, pada kasus-kasus trauma, Pak Wallace, apakah boleh dilakukan pasien dengan trauma torak? Ya. Trauma torak, fraktur iga atau fraktur sternum, dia cardiac arrest. Itu kontraindikasi atau juga harus tetap dilakukan kompresi pada kondisi cardiac arrest. Pasien-pasien multiple trauma ketika mengalami cardiac arrest itu tidak ada kontraindikasi untuk dilakukan resusitasi jantung dan paru. Jadi pada pasien-pasien trauma torak, trauma abdomen, ya, atau bahkan pasien-pasien yang mengalami fraktur sternum, fraktur koste, ketika cardiac arrest, tetap hukumnya wajib dilakukan resusitasi jantung dan paru. Lah Pak Wallace, nanti patahnya semakin hebat dong. Nah, kalau patahnya semakin hebat, yang pasti jantungnya selamat dulu, dia hidup dulu. Masalah fraktur nanti dikonsulkan ke dokter ortopedi. Nah, pasiennya amankan dulu, selamatkan dulu dengan melakukan pertolongan pada kondisi-kondisi kegawat daruratan. Nah, di dalam AHA 2010 di sana dikatakan bahwa untuk pasien-pasien suspek fraktur servikal itu sudah diindikasikan untuk buka jalan napasnya jaw thrust, dan itu tetap direkomendasikan di AHA 2020. Karena pada kondisi-kondisi multiple trauma kecelakaan lalu lintas ada sekitar 0,12 sampai 3,7% pasien-pasien yang mengalami henti jantung mengalami cedera servikal, sehingga kita harus hati-hati. Juga ketika kita mendapatkan pasien dengan kesadaran menurun, riwayat multiple trauma, ada jejas di daerah kepala atau brain traumatic injury, atau pasien-pasien yang suspek ada fraktur servikal. Berikutnya adalah breathing. Breathing bisa dilakukan dengan cara memberikan bantuan napas. Kita kenal bantuan napas dari mulut ke mulut, tapi hati-hati ya, kemarin ini tidak direkomendasikan pada penata laksanaan di masa pandemi COVID-19 ya. Mode to mask dengan menggunakan alat, atau kita menggunakan pocket mask, atau juga bahkan mode to stoma. Ini adalah bantuan napas yang sudah sering kita dengar, atau bahkan teman-teman pernah melakukan dalam kondisi kegawat darurat di pra-rumah sakit. Tetapi ketika ada kondisi kegawatan di dalam rumah sakit, intrahospital cardiac arrest, maka saya yakin di setiap rumah sakit pasti ada back valve mask. Bagaimana back valve mask ini yang kita gunakan sebagai support breathing secara adekuat. Jangan lupa ketika kita menggunakan back valve mask, pastikan aksesoris back valve mask-nya itu lengkap. Jangan sampai juga reservoirnya nggak ada, klemnya nggak ada, atau bahkan kita lupa, saking saking gugupnya lupa nggak dikoneksikan ke sumber oksigen. Nah, itu yang terkadang ketika ada kondisi kegawatan suka lupa. Ini mohon perhatian bagaimana tetap support oksigen disambungkan ke sumber oksigen 10-15 liter per menit. Bagaimana teknik megangnya, ya jangan sampai udaranya nggak bisa masuk, atau kalau orang Jawa bilangnya belepetan keluar lewat samping pipi, ya. Tidak ada pengembangan rongga dadanya, berarti back valve mask yang kita lakukan bantuan napasnya nggak maksimal. Ada dua kemungkinan, ya. Posisi jalan napasnya nggak terbuka, atau teknik megang kita yang tidak adekuat. Teknik megang E-clamp, EC-clamp, ini harus menjadi perhatian kita. Ngomongnya simpel, tapi pengalaman di klinis nggak semudah yang saya sampaikan. Mungkin teman-teman punya pengalaman bagaimana teknik memegang back valve mask ketika kita ventilasi betul-betul bisa masuk ke paru-paru pasien. Nggak semudah yang kita bayangkan, nggak semudah ketika kita menggunakan manikin. Beda ketika kita hand-on langsung ke pasien. Harus ada jam terbang yang tinggi, ya, pengalaman klinis yang baik, sering memberikan bantuan napas pada kondisi-kondisi kegawat daruratan. Nah, kapan kita melakukan evaluasi? Evaluasi dilakukan setiap 5 siklus dievaluasi. Ya. Kita memberikan bantuan kompresi 30 kompresi 2 ventilasi, 30 kompresi 2 ventilasi, 30 kompresi 2 ventilasi, 30 kompresi 2 ventilasi, dan 32 kompresi 2 ventilasi, itulah satu siklus. Nah, cek ada tidaknya nadi karotis. Kalau tidak teraba, lakukan satu siklus lagi. Jika nadi teraba, napas tidak ada, berikan bantuan napas selama 2 menit. Setelah 2 menit, apa lagi yang dilakukan? Evaluasi. Evaluasinya mulai apa? Mulai C-nya lagi, cek nadinya. Jangan-jangan tadi nadi sudah teraba, napas tinggal napasnya aja yang nggak ada, ini penurunan lagi, nadinya hilang lagi. Ketika nadi sudah ada, napas sudah ada, berikan recovery posisi. Yang harus diwaspadai adalah bahwa henti jantung, henti napas bisa saja berulang. Sehingga penting sekali ketika pasien sudah kita berikan recovery posisi, tetap melakukan monitoring, melihat kondisi pasien secara real time. Ya, ini adalah posisi recovery posisi yang bisa dilakukan di kondisi prahospital. Kalau ada posisi di dalam rumah sakit, tentunya dengan memberikan posisi semi-collar, tetap memberikan support oksigenisasi. Nah,
sekedar mengingatkan Bapak bahwa waktunya tinggal 5 menit lagi.
Siap.
Terima kasih.
Apa yang membedakan pertolongan orang awam dan tenaga kesehatan? Ini adalah yang harus kita perhatikan, bagaimana kita memberikan pertolongan, baik tenaga kesehatan maupun orang awam terlatih. Yang pasti di sini adalah bagaimana kita memastikan sebagai tenaga kesehatan tetap melakukan cek respon pasien dengan mengecek nadi karotis. Tetapi untuk orang awam, dengan memastikan bahwa pasien ini tidak sadar, tidak ada pengembangan dada toraknya, berarti kita harus melakukan resusitasi jantung dan paru. Tadi sudah disampaikan juga bagaimana kita melakukan high quality CPR dengan kecepatan 100-120 kali per menit, dengan kedalaman 5-6 cm, harus memperhatikan recoil chest compression, torak itu betul-betul mengembang kembali. Kita harus meminimalkan interupsi, memberikan bantuan napas yang adekuat dengan teknik megang yang adekuat juga. Ketika kita capek, diganti oleh kompresor berikutnya, tentunya tidak boleh lebih dari 5 detik, harus bisa tergantikan. Itulah pentingnya komunikasi sesama tim ketika kita kelelahan memberikan kompresi. Nah, bagaimana di masa pandemi COVID-19? Ini saya mengingatkan kembali bahwa yang harus diperhatikan adalah meminimalisir paparan ke penolong berikutnya, APD lengkap, membatasi personil, ya, menggunakan perangkat resusitasi jantung paru mekanis kalau ada, ya, komunikasikan kepada tim kita bahwa pasien ini adalah pasien kategori COVID-19. Memperhatikan juga prioritas oksigenisasi, misalnya dengan penggunaan HEPA filter, intubasi sesegera mungkin, hentikan kompresi saat intubasi. Ini adalah hal-hal yang perlu dipertimbangkan untuk meminimalisir paparan COVID-19 di masa pandemi COVID. Ini gambaran HEPA filter yang sering kita lihat, bagaimana ini juga mensupport safety kita dalam pelayanan penata laksanaan cardiac arrest. Penggunaan APD, tentunya ini sangat direkomendasi di masa pandemi COVID-19 kemarin. Sejawat kita yang ada di ruang bangsal perawatan COVID-19 memberikan pelayanan yang terbaik. Yang tak kalah pentingnya di dalam penata laksanaan kecepatan respon penanganan cardiac arrest adalah penggunaan automatic defibrilasi. Alat ini adalah alat untuk memberikan kejutan atau shock listrik pada henti jantung dan henti napas secara otomatis. Tentunya penggunaan juga relatif mudah, ya, mengikuti alur yang dilakukan, diinstruksikan di alat AED yang kita gunakan. Nah, kapan sih RDP itu dihentikan? Tentunya ketika pasien sudah spontan, dia jantungnya berdenyut, napasnya ada, atau kita kelelahan. Ya. Tentunya kelelahannya juga sesuai standar berapa lama kita telah melakukan pertolongan pada kondisi cardiac arrest. Berikutnya adalah pasien-pasien kategori do not resusitasi atau pasien-pasien sudah ada tanda-tanda kematian yang ada kaku mayat, lebam mayat, pupil menebal atau refleks cahaya sudah tidak ada. Yang harus diperhatikan terakhir adalah komplikasi yang mungkin saja bisa terjadi pada resusitasi jantung dan paru. Yang pertama akibat bantuan napas, sering kita dapatkan inflamasi gaster. Ini tentunya ketika buka jalan napasnya nggak maksimal, ini akan berdampak masuknya bantuan napas tadi ke lambung. Dampaknya inflamasi gaster, regurgitasi. Dampak yang kedua adalah akibat kompresi. Ya, bisa fraktur iga. Kalau posisi tadi kita nggak adekuat, ya, posisinya tidak adekuat atau selalu ke sebelah kiri atau ke sebelah kanan. Bisa juga terjadi pneumotorak, hematotorak, kontusi paru, laserasi limpa, hati, emboli lemak, dan tentunya akibat ini bisa kita minimalisir ketika kita melakukan titik kompresi sesuai dengan yang telah ditentukan. Di samping itu juga bahwa dampak dari kompresi ini juga bisa juga diakibatkan oleh faktor pasiennya itu sendiri, terutama pasien-pasien yang sudah relatif tua, usia lanjut, ini juga bisa saja kemungkinan terjadi fraktur iga ataupun komplikasi yang lainnya. Terima kasih, itu paparan mengingatkan kembali pada kondisi-kondisi tentunya sudah sering kita lakukan, mudah-mudahan banyak bahan diskusi, sharing informasi terkait penata laksanaan yang teman-teman temukan kondisi cardiac arrest di pra rumah sakit ataupun kondisi cardiac arrest yang kita temukan di dalam rumah sakit. Terima kasih, waktu saya kembalikan ke moderator.
Oke, terima kasih Pak Welas atas penjelasannya, sangat luar biasa. Meskipun ini time by time, mungkin setiap waktu Bapak menjelaskan tentang ini, tapi bagaimanapun emergensi itu memang sesuatu yang menarik untuk disimak. Oke, ini ada satu pertanyaan Pak Welas. How your experience to train the lay people about CPR. Jadi bagaimana pengalaman Bapak Welas ini melakukan training terhadap orang awam untuk CPR? Apa Pak kesulitannya dan harus bagaimana nih? Pasien yang orang yang seperti apa yang boleh ditolong oleh orang awam dengan CPR ini Pak? Itu pertanyaannya.
Bagus sekali bahan diskusinya, ya. Ada beberapa hal yang harus kita kuatkan ketika kita melatih bantuan hidup dasar kepada masyarakat awam. Nah, yang paling sulit adalah ketika kita memberikan bantuan edukasi kepada masyarakat awam yang betul-betul dia minim pengetahuan terkait dengan kesehatan. Ya, kalau kita belajar dari pengalaman teman-teman di Hibgabi di semua provinsi, ya, melatih teman-teman bapak-bapak polisi, teman-teman di pemadam kebakaran, teman-teman di BPBD, teman-teman di PMI, teman-teman di EMT, itu lebih mudah dibandingkan kita memang betul-betul memberikan informasi ke masyarakat awam yang tidak paham mengenai pelayanan kesehatan. Itu yang paling sulit. Nah, penguatan-penguatan yang bisa dilakukan adalah bagaimana memastikan pengetahuan masyarakat awam itu tahu, oh ini loh yang cardiac arrest, ini yang bukan. Kalau orang awam kan nggak kita latih untuk bagaimana dia cek nadi karotis untuk orang awam. Orang awam hanya kita informasikan bagaimana mengetahui bahwa pasien ini cardiac arrest. Orang awam tahunya kalau pasien henti jantung, henti napas adalah dadanya nggak kembang kempis. Itu yang kita mudahkan. Kalau Bapak Ibu menemukan orang tergeletak, dilihat dadanya nggak kembang kempis, nggak naik, nggak turun, itu cardiac arrest. Yang harus Bapak lakukan adalah itu aja, tekan di tengah-tengah tulang dada, kecepatannya 100 sampai 120 kali per menit. Sampai kapan? Sampai capek. Kalau capek, ganti penolong yang lainnya. Itu penguatan yang bisa kita berikan kepada masyarakat. Kemarin juga dilakukan oleh teman-teman dari Hibgabi DKI, Mas Wahyu, RSKO. Ketika akan ada pertandingan sepak bola di Istora, ya teman-teman Hibgabi DKI bersama teman-teman dari Rumah Sakit Ketergantungan Obat RSKO di bawah komando Bang Wahyu itu memberikan edukasi kepada penonton, ya, bawa manikin di sekeliling Istora Senayan. Nah, itu adalah bentuk aware kita bagaimana masyarakat awam juga ketika ada kondisi kardiak arrest tuh, oh ini loh yang dilakukan. Nah, yang paling sulit memang masyarakat awam yang pemahaman akan mengetahui kondisi kardiak arrest itu sulit. Tapi kalau ke teman-teman Bapak polisi, ke teman-teman pemadam kebakaran, pengalaman dari teman-teman Hibgabi relatif mudah.
Oke.
Teman-teman ada pengalaman juga, bisa share pengalamannya nih.
Oke, audiens, ada yang punya pengalaman untuk melakukan training terhadap orang awam? Yang ada waktu itu kami pernah mengadakan di Fitkes itu untuk anak-anak SMA, Pak.
Oh, betul, betul.
Ya, mereka amat sangat excited, sangat amat tertarik untuk mereka dilatih untuk emergency CPR nih. Memang luar biasa gitu.
Ya.
Ketertarikan
itu ada juga
mereka.
kalau teman-teman yang ada di institusi pendidikan nggak tutup kemungkinan untuk ke masyarakat itu pengabdian masyarakat ya, pengabdian masyarakat bisa melakukan pelatihan itu buat teman-teman pramuka ya, OSIS di SMP. Nah, saya yakin itu adalah hal yang bisa ditindaklanjutin oleh teman-teman yang ada di institusi pendidikan, gerakin mahasiswanya ya. Nggak harus tersertifikat ya. Pak Blas, kalau nggak TBAD harus sertifikat apa sih ya? Ini kan kita menularkan ilmu yang baik buat teman-teman. Ketika teman-teman sudah confident bahwa saya bisa sesuai dengan standar yang ditentukan, ya, boleh memberikan informasi kepada orang lain. Orang awam boleh gitu loh. Syukur-syukur teman-teman sudah punya sertifikat bantuan hidup dasar atau melalui yang pelatihan BTCLS atau emergency nursing. Itu kan di dalamnya ada muatan bantuan hidup dasar. Kalau teman-teman sudah mengikuti pelatihan itu, it's okay, ya, nggak perlu TOT, trainer of training untuk BHD gitu ya. Ketika teman-teman sudah kompeten, sudah mampu melakukan dengan baik, dengan maksimal, teman-teman boleh menularkan itu kepada lingkungannya, ya, di lingkungan RT, ya. Kalau bapak-bapaknya malam Jumat itu pengajian, di dalam pengajian itu disisipkan bagaimana melakukan BHD gitu. Waduh, Pak Ulas nggak punya manikin saya gitu. Ya pakai bantal, pakai apa loh? Ajarin tekniknya gitu. Nggak usah terbatas dengan harus ada manikin.
Baik.
Syukur-syukur punya manikin biar memastikan posisinya di sini gitu, lebih bagus lagi. Ibu-ibunya yang suka arisan. Yang suka arisan ya ngomongin nggak usah ngomong Tupperware, dandang, kuali, sotel, irus ya. Sekali-sekali ya ngomongin BHD buat ibu-ibu di pengajiannya, di arisannya gitu.
Iya Pak, ini sangat menarik sebenarnya. Tapi ada satu pertanyaan saya, mungkin di pertanyaan yang terakhir ya Pak. Untuk sebaiknya untuk calling emergency itu sebaiknya apa yang dikatakan? Sebab kalau saya lihat di Malaysia itu Pak, kalau mereka calling emergency itu pasti satu menyebutkan nomor KTP. Karena begitu diketik di dalam komputer namanya KTP-nya itu siapa gitu, nanti langsung keluar. Jadi mereka tidak bohong, sebab kalau mereka main-main dengan emergency, hukumannya sangat berat di sini. Bagaimana dengan di kita, Pak, untuk calling nih ke emergency? Apakah ada caranya atau gimana nih, Pak?
Oke, kalau di Malaysia memang sudah bagus ya. Dia punya trauma center ya di Hospital Kuala Lumpur. Saya pernah 3 minggu di sana dengan tim teman-teman yang ada dari Fatmawati. Kita ada di Kuala Lumpur Hospital. Nah, emang dia punya jejaring seluruh Kuala Lumpur itu ketika ada memanggil kondisi gawat, dia terhubung di sana. Nah, begitu juga di Indonesia sebenarnya juga sudah ada. Ya, kita punya nomor 119. Jadi teman-teman ketika ada kondisi gawat darurat silakan hubungin 119. Akan diterima call center-nya 119 yang ada di Kuningan Rasuna Said. Nah, nanti di 119 itu pasti akan ditanya alurnya, ya. Siapa yang telepon, ya, kondisinya seperti apa, nanti akan diberikan alur. Ya, di dalam 119 itu ada alurnya. Ketika ada laporan misalnya lapor pasien misalnya pasiennya nggak sadar. Pasti tanya nggak sadarnya kenapa ini, tahu nggak ceritanya gitu. Pasti ada dituntun oleh 119. Di samping nanti 119 akan juga menghubungin wilayah, kalau di DKI itu ada AGD Dinkes ya. AGD Dinkes itu akan dikoneksikan ke AGD Dinkes. Itu sepemahaman saya di dalam jejaring komunikasi panggilan gawat darurat di Indonesia melalui koneksi 119. Itu bisa diakses dari seluruh Indonesia. Dia akan larinya ke Kuningan.
Oke. Jadi kita udah ada 119 untuk seluruh Indonesia ya Pak ya?
Betul.
Oke, terima kasih. Oh, masih ada yang hand raise ya. Agus Jailani. Halo Pak Agus. Halo Pak Agus. Oh, rupanya ada kendala Bapak. Jadi angkat tangan, tapi orangnya nggak ada sepertinya. Oke, waktunya sudah habis Pak Welas. Saya rasa terima kasih atas kehadirannya Pak Welas. Cukup mencerahkan pengetahuan kita tentang emergensi. Oke, jika Pak Welas ada aktivitas yang lain, boleh silakan meninggalkan webinar ini. Terima kasih Pak Welas.
Bu Musi, terima kasih pada Madani, terima kasih pada Bapak Ibu sejawat semuanya atas keluangan waktunya di hari Sabtu yang biasanya teman-teman ini sudah weekend, tapi ini masih betah di depan perangkatnya.
Iya betul Pak.
Menambah informasi, menambah pertemanan, menambah jejaring. Mudah-mudahan kita semuanya tidak dalam kondisi gawat darurat. Kalaupun ada kondisi gawat darurat, kita sudah punya kenalan ada dari Sumatera sampai dengan tanah Papua. Sehingga ketika kita jalan-jalan weekend, aman. Kalaupun nggak aman, ya adalah di wilayah masing-masing yang ada di jejaring sore hari ini. Saya yakin pada punya kemauan yang baik untuk saling silaturahim, saling penguatan, saling penata laksanaan kondisi kegawat daruratan sehingga masyarakat kita dan kita semuanya selamat dari kondisi kegawat daruratan. Terima kasih. Akhir kata, kurang lebihnya mohon maaf. Bila taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Selamat sore.
Waalaikumsalam warahmatullahi wabarakatuh. Oke. Untuk pembicara keempat ini saya akan bacakan untuk conclusion atau kesimpulannya, yaitu Pak Welas membicarakan tentang update BCLS Children and Adult ya. Jadi kondisi gawat darurat itu dapat terjadi kapan saja, pada siapa saja dan dimanapun berada. Oleh karena itu perlu adanya training untuk orang awam melakukan CPR karena beberapa alasan yang saya rasa sangat penting. Yang pertama adalah karena 95%, ini menurut satu penelitian, bahwa pasien-pasien ini meninggal di luar hospital. Ya, jadi memang kekurangan perawat atau dokter yang bertugas di out of hospital. Oleh karena itu, ini alasan penting kenapa perlu dilakukan training untuk orang awam. Yang kedua, kalau otak ini tidak mendapatkan oksigen selama 3-5 menit, maka akan terjadi hypoksia atau kekurangan oksigen di dalam otak. Sehingga hal ini bisa menyebabkan kerusakan otak. Ini juga penting. Kenapa perlu dilakukan pelatihan untuk orang awam untuk melakukan CPR. Kemudian yang berikutnya adalah alasannya adalah karena peluang keberhasilan untuk menolong orang dengan cardiac arrest, menit pertama boleh 98% ada harapan untuk hidup. Kemudian 5 menit kedua ada 50% kesempatan untuk hidup, sedangkan kalau sudah 10 menit itu hanya 1% saja. Oleh karena itu kita perlu untuk melakukan training terhadap orang-orang awam untuk melakukan atau bisa melakukan compression saja, ya. Menurut AHA 2020, di sini yang berbeda terutama adalah rantai ke-6, yaitu tentang rehabilitasi terutama, ya. Kemudian untuk dalam AHA, American Heart Association itu adalah dimulai dengan DRS CAB, yaitu danger, kemudian respon, shout for help, kemudian circulation, airway, dan breathing. Ini adalah urutan yang penting untuk dilakukan pada saat melakukan CPR. Ya. Saya rasa hal itu adalah conclusion atau kesimpulan yang telah disampaikan oleh Pak Welas untuk sore ini. Oke, emergency condition can happen to anyone, anytime, and anywhere. So there is needed for training in life rescuer. The reason it's important because the research revealed that 95% the patient dead out of the hospital, and 3 until 5 minutes the brain reduce supply oxygen or no supplies oxygen to the brain. It causes hypoxia and causes brain damage. And chance of opportunity in cardiac arrest, 1 minute, the patient can survive in 98%, in 5 minutes, 50%, and 10 minutes can survive only 1%. I think that is the conclusion today from the 4th speaker. Okay. Thank you for all audience present in the webinar in the afternoon, and the time will be back to MC. Bu Murti, please, I beg your time. Halo, Bu Murti. Okay. Please, it's yours.
Sorry. Okay. Sorry. My voice is unmute. Thank you, Mrs. Musri as the moderator. Thank you to all the speaker for providing the new insight and knowledge about update basic trauma and cardiac life support in nursing services. And also, thank you very much to the audience for your kind attention to this international nursing webinar with number of participants, almost 700 participants. It's amazing. That was held by Madani Heart Training Center and Master of Nursing Program, Jenderal Ahmad Yani University. Hopefully, you will get useful knowledge, especially for nursing services. As a Master of Ceremony, I apologize if there are words that are not good and there are things that make you uncomfortable. For audience, don't forget to fill the evaluation link in chat box. Thank you, goodbye, and see you again in tomorrow on the second day of the nursing webinar. Bye-bye, sampai jumpa lagi. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Profesional dan rendah hati, siap melayani dan berbakti. Membangun negeri tercinta, sehat sejahtera bangsaku. Siang malam sepanjang waktu, langkahmu selalu ditunggu. Tak membedakan umat, semua dilayani. Dengan cinta tulus dan dedikasi, kau bawa talenta suci.
Isn't it amazing how almost every line on our hands align? When your hands are mine, it's like I'm whole again. Isn't that a sign? I should speak my mind.
I've said those words before, but it wasn't right. You deserve to hear it 1,000 times.
If all it is to say that, why is it so hard to say? If all it is to say that, why am I in my own way? Why do I pull you close and then ask you for space?